Yes, you can. Yes, you have the ability to share.
Okay, so I'm trying to, since I found a section with drugs, it's not seeing a whole lot of anything, which is not unusual.
What's that? You find it difficult to find resources?
No. So I'm in the EMT curriculum under
Mhm.
pharmacology, and I'm specifically looking at the EMT lesson plan, and I'm trying to see where they would have they. Let me just open it up so you can see what I'm saying. It's not because it's EMT. They kind of simplified the stuff that would incorporate the math under pharmacology. Now, if I can find an advanced or paramedic curriculum, it would be much more than this.
Got it.
Yeah. So, because this one is given the name of the drug, the action, the contraindication, and the routes and the side effects, and it's telling you what the dose is, but there's really there's not a concrete expectation for the EMT to have to calculate the dosages for what they
Got it.
like an aspirin or or if it's a Benadryl, take it, it tells you what to take.
Right. So it's not requiring the paramedic do a calculation to
No,
know.
is not requiring the EMT to do a calculation because the EMT is a lower is lower than the paramedic. So
Okay.
it's not requiring the EMT to do a calculation.
So the EMT is only being asked to administer a dosage, but the actual paramedic would have to know how to do a calculation.
Correct,
Got
correct,
it.
correct. Because you have a drug box, you have different types of medication that you give, and you have to be able to know how much to give because it's by a lot of it is by weight. I'm just trying to I'm trying to get to a this is all I'm looking in pharmacology in the EMT, and yeah, there's not a lot of let me try to look at national registry.
Is it possible for you to share your screen so I can see what you're looking at?
Yeah, I'm okay. I can. I'm just switching over to a whole nother thing because let me share. Where am I? I can come back here. I am in this one. Are you seeing my screen?
Yes, I can.
So this is where I was when
Is this open to the public or is it something that's solely for instructors?
this is a learner management system. This is a system that you have to pay to use this. This is the curriculum.
Got it. And
So
does the school pay for this or do you pay for it personally?
no, the school paid for this. For my own personal one, I have one that I paid for, but this is, the same information, but I'm on the school's one. Right.
Okay.
So this is pharmacology. So
Mhm.
this is what it would look like. So I was trying to go and look and see where the math would be in this.
What happened when you did you try to type Control F?
What do you mean?
If you just type Control F, you should have a find box pop up in your browser. just type press the control key and then the letter F at the same time. Let's see if it comes up.
Uh-huh.
Did you press it?
I did.
Okay, so you see to the left where it says find,
Uh-huh.
type in what you're looking for. So if you're looking for, let's just say, I don't know, math or what would they refer to it as?
Yeah. I was gonna go down to the let me see. No mention. Oh
Okay,
wait, I have to spell that word right.
yeah, and yeah, the more go ahead.
Yeah.
So it has just try math and see if anything comes up. So you see where it says no matches. What type of term would it use? Would it use terms like milligram or mg?
Let me see.
No matches.
Uh,
Um,
um, um, um.
maybe they don't have the a math section. Is that
Yeah, because
possible?
that's why I was looking under pharmacology. They don't have a math section per se. Now I will tell you this. Let me go over here. Let me go back to this. No, not that, not that. Um, nope, nope. Um, it might show up here. Yeah, so this is
What was the name of that document?
I googled okay, you see where my um you see where the arrow is right here on the
Mm-hmm.
top. EMT
Mm-hmm.
paramedic national standard curriculum
Mm-hmm.
diagram of educational model. Now you look down here, see where you see on the competency, you got mathematics,
Mm-hmm.
reading, and writing.
Right.
Now, the only thing about this is that when I got to this, I was hoping it was going to take me to the section, but this is a paramedic curriculum right here, this whole thing.
Mm-hmm.
All right, this is it's a little bit it's more updated, but this is the crux of what it is,
Okay.
and as you see here, it has mathematics, and so under where oops, why did that do that? Oh, trying to see where. Hmm. See, in there in the textbook, it breaks down pharmacology into sections, and I don't see it. Trauma, hemorrhage, social burns. Yeah, see, okay, so they have the mathematics listed up here. Oh, here it is. Okay, pharmacology is what I was looking for. I was looking for um the introduction. The introductory would be here. But now the only thing about this, I thought I was going to be able to scroll in and to get into a document. So this is not allowing me to do that.
Mm-hmm.
So what I was trying to do was go into um let me see. Education. Let me see. Hmm. Let me just see. Education review. For, um, okay, let's see. Ah, he got an app. So let's
Mhm.
um, sometimes they have hmm, IV solutions and fluids. Yeah, I thought I was gonna be able to pull up something that you could see. Now in the textbook I could show you, but I'm trying to find something to here. Let me go on the nursing thing for a minute. Let's just see. Hmm. Hmm. Here we go. What? Hmm. Mhm. Let me get somewhere here. Let's see. Mm. Mm. What? Huh. These things are not here. Okay. Let's see. All right, he says before, he said hit function F. Hmm. I did that function F thing you said, but it's
Yeah, you type it there. And then if it says, if you just type, try, so the more specific it is, the less likely you are to get, there you go. So you see how you put medical and it says there's three, you're on the number three of 147 times medical is being mentioned. So if you click the arrow up, so if
but
you, to the right, if you click that, it'll take you to the second one out of 147. You click again,
oh, because they're oh.
it'll take you to the first out of 147. So that means that the word medical is in this document 147 times. So if you're looking for the word dosage or CC or a specific math term that's used in the industry,
Ah, here we
there
go.
you go. So you have dose 9 times. And that's the first time in this document the word dose is used, and you can scroll through the different times dose is used. So, given professionals, in fact, medication errors are the cause of
Go back.
1.3 million. Wow.
When you go back to where were you reading? Go back to something.
Yes, please.
Where should I go back to?
How did you get to where you are? Did you click down? Just click back, click the arrow the other way. Yeah. So if you look at the top of page B4,
Oh
it
yeah,
says it
yeah.
says
In fact, but yeah, it's a big number. I knew it was a big.
yeah, it says time and expiration dates that the container contains medication label says intent. Medication errors happen all too often in the United States, even when drugs are given by professionals. In fact, medication errors are the cause of 1.3 million injuries each year.
Mhm.
These errors are due to the wrong drug dose, timing, or route of administration,
Mhm.
preparing,
Prepare
giving,
and
and
giving.
evaluating the effectiveness of prescriptions and non-prescription medication is not in the scope of practice for EMS personnel. let me get this right. Preparing, giving, and evaluating the effectiveness of prescriptions and non-prescription medication is not in the scope of the practice of for EMS personnel.
So what they're saying here is that, okay, now let me just say this, well, because this could be kind of confusing. But when it says preparing and giving, they're talking about we don't make medications and we don't
Got it.
prepare them. But we have a set vial that's already prepared. We just
Mm-hmm.
gotta screw it together and then give it.
Mm-hmm.
But we gotta know what we're giving. You see what I'm saying? But we don't
Right.
we purchase, with whatever company we're working for, whatever, they have a set supplies of drugs and medications that we do have to check every day, make sure that it's not expired, or it hasn't been tampered with, or and all those. And if it has to be, if it's expired, we need to change it out.
Mm-hmm.
Okay, and make sure that it's clear. It's supposed to be clear fuel. Make sure it's clear and not cloudy.
Right.
So that's what that means. So that could be a little bit confusing. But what they're saying is that uh EMS personnel don't do that, but we have them from other people who already did all those things, who prepared them, but we have to
Mm-hmm.
know how to give it.
Right.
And sometimes if we're given an order by a doctor, okay, I need you to give XYZ milligrams per kilogram, you gotta know how to give it.
Right.
Yeah.
But there seems that there are a lot of there are a lot of I'm sorry, medication errors.
Oh yeah. Oh,
Mm.
yeah, that's a fact. Now that's one we need to talk about that, but yeah, and I mean it's not my first time seeing this, and that's one of the reasons why but with pediatric patients, you have a little like a cheat sheet to make sure, depending on the pediatric patient, it could be from birth to 1 and then 1 up to 8. So when you're giving drugs to kids, you're allowed to look and make sure about what you're giving. Now to me, if you're doing that for kids, why not do it for everybody?
Mm-hmm.
You know what I'm saying? But yeah,
Mm-hmm.
because that medical error, particularly, they look at infants and kids a little bit different, but it's still bad.
Right. Is the rate of medical errors in children less than in adults?
I honestly don't know.
Mm.
Um, but because of I'm guessing in terms of medications, I'm guessing that there's less of a medical error because you do have that at your fingertips.
Okay. So here's my question. I have a few questions, and it would be great if we can use the chat to kind of start to get some concrete um, actionable items. Um, so one of my questions is, what are the most commonly used measure medical measurement tools used by, and we're gonna tailor this to paramedics.
Or you could say EMS if you want, or both,
Okay, so by EMS.
which is emergency medical services.
Okay. So what are the most commonly used medical measurement tools by EMS? So there, and please feel free to type in the answer because I need to definitely get this information from you. So let's say that there is a EMS professional that just came into work and he's about to go out on a call. I'm sure that there might be a need for a drip bag and there might be a need for some type of way to administer um, some type of injection. What
Mhm.
tools are used other than the drip bag and syringe? What tool are those? The two tools that the EMS would need, or are there other measurement tools that would be needed as well?
So the IV bag, is
Okay.
one. Okay.
Mhm.
Um,
Please check, please type it
oh,
in the chat.
okay. Well,
I'll type it. I'll start typing. You just tell me. So it's the
well,
IV bag.
well, I need to move it over. I can do it. I just need to move it over. It's, I don't know if you, I just need to move. I needed to move it over to where I could. Okay. All right. So, um, hold on one second. Let me just, cause I don't want to miss anything. So let me just pull something up. I actually have a pharmacology book that I can put my hands on. Let me see here.
Can you hear that in the background?
No, I just heard some go boom, but it was a lot, it was a light sound. Okay, so
So a cc is a milliliter.
cubic
Hello?
centimeter is a milliliter, yes. Cubic centimeter is the same as a milliliter.
So a cc means cubic centimeter.
Mm-hmm.
So it's volume.
Yes.
Okay. And you typically use saline bags as a paramedic. Is that the case? A paramedic
Well,
IV bag?
yeah, it's not just saline. Um, you have normal saline, you have dextrose, which is sugar,
Got it.
and lactated ringers.
Okay.
Those are the main.
Are those the only three IV bags that are used?
Those are the main ones that for EMS. I'm trying to think of.
Do EMS also carry blood IV bags?
No,
So if someone is losing blood and they need blood, what is typically done in scenarios like that? Just hurry up and get to the hospital?
no volume. The ringers or the normal saline just for volume purposes.
Got
Because
it.
the problem with the blood is being able to keep it and whether conditions of how the unit run. They did studies on that because they talked about it one time. So they talked about doing that one time. So I think some areas where they have long transports, that
Hmm.
jurisdiction may have it, but
Hmm.
the unit has to be set up to be able to maintain, the temperature of it, like a refrigerator
Got
and
it.
all that kind of stuff to
Hmm.
to, to keep the integrity of
So so does plasma help instead of blood?
the same thing. It's certain conditions that you have to have. So what happens is they take the blood and they spin it down,
Hmm.
and then uh, there's actually a company that does stuff with the plasma, but we don't do anything with plasma. Not the 911 is just 911.
Got it. Got it.
Yeah,
So 911's job is to get someone to the hospital as soon as possible.
correct.
So the thing is to sustain life until you can get them to the hospital.
Correct.
Mhm.
And so whether it's a medical patient or trauma patients, typically trauma patients, you want to spend less time on the scene because those patients tend to need a surgeon. But you get there and stabilize them, call it in so that the team at the hospital can be ready when you get
Mhm.
there.
Mhm.
And if there's certain things that could be done on the scene, it will be done on the scene. And that's where the advanced cardiac life support comes in. And
Mhm.
so now I can share. Let me pull that up because there's an algorithm for that that's pretty let me see. Let me see.
While you pull that up, in addition to the IV bag, are syringes commonly used?
Oh yeah, 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 yeah. Absolutely. Yeah.
Okay.
Yeah. The syringes, because that the pharmacology book that I have that I'm trying to find, it actually has the different size syringes to show you what, 0.5 ml, 0.234, all the way up to 10 looks like, so that a person have an idea what it looks like when you're in training. Um, I don't want that.
Other than the IV bag and a syringe, is there anything else used to measure liquid volume?
Um,
Like if someone had to take an oral dosage of something, would that be in a syringe or
Nebulizers, you do nebulizers.
okay,
So a
so
net treatment, it will come in a small little plastic, not a vial, but it's a plastic container, but you put it in neb treatment because you mix it with oxygen, you pour it in like a little cup,
hmm.
and they'll breathe it out.
Is there calculations required for nebulizers?
No, you just to open it up and pour it in.
Got it. So is there a ratio that you're supposed to use?
So you give it to a patient, and when they inhale and exhale, as the mist empties out, you'll do another assessment and see what kind of effect it had on them in terms of, um, did it remain the same? Did it make it worse? Did it get better?
Got it. So it's just a more of a an individual observation versus a calculation.
It's both.
Okay.
Because
So
like for like tablets, like for example, put tablets up there also, the nitro tabs.
mhm,
Um, you can only, depending on what the person's blood pressure is, you only give it depending on what the blood pressure is. If it's
mhm,
less than 90, you don't want it. A person who has chest pain is who you're going to give this to. But you got to make sure, okay, they may have chest pain, but what are their vital signs?
mhm.
Um, if their blood pressure is like 90, is less than 100, okay, then, well, you won't want to give it to them because you're opening up their vessels. And if it's these patients usually have high blood pressure and you want to bring it down. But if
Mhm.
they're having chest pain and their blood pressure that you take and it's already down, that's a contraindication not to use that.
Got it.
Then when you give it, you only want to give it no more than 3 times in a particular setting. So, it's
So
you
what I'm trying to zero in on is where throughout the day is calculations and mathematics required in the day-to-day practice of an EMS.
when they're running a code or your medical patient. But again, those, let's see here, medical patient, trauma patient, pain management,
And how is that got,
morphine,
got it.
yeah. And not every jurisdiction gives it, but um, and you have some other ones too. Oh, you usually put, fentanyl, which is what they putting in drugs these days. The over the counter stuff, but
So how are these drugs administered?
IV.
Okay, so
Well, okay, no, I'm sorry. Okay, it could be IV or could be IV or IV push, meaning it could be in a bag or it could be given directly with the needle. So it depends on what you're giving it for. Because
okay,
it could be like in a drip or you can give it direct.
okay, so direct would mean with a syringe.
Yes.
Okay,
But
so
it's still cooked up. It's with a syringe hooked up to IV access. You still have IV access with a syringe.
got it. So it's just how it's being accessed. So you have so either way the dosage is coming from an IV bag.
It could be coming from the syringe
Hmm.
directly that's attached to an IV access, which is small, direct.
Hmm.
And hold on a second. Hello?
Yes, I'm very much here.
Okay. What was the last question?
Okay, so what I'm trying to do is just basically identify number one, class starts on August 28th, and it's pretty much very close to September 1st. The goal that I was trying to make sure happened was you would have certain supplemental material to provide to the learners as practice for daily practice, focus solely in one area of measurement. So let's say, for instance, for the first quarter, we just focus on IV bags. Or even for a month, we just focus on IV bags. And then the next month, we focus on syringes. And then the next month, we focus on, something else. And we just start off with liquid volume and everything that involves liquid volume for the use of a paramedic. And then, for instance, I didn't know, I always heard the term cc's like on television shows and stuff,
Mm-hmm.
but you just taught me today it means cubic centimeter.
Mm-hmm.
Okay. And then a cubic centimeter is the same thing as a milliliter.
Mm-hmm. Mm-hmm. Yep.
So that's very important information to know. But then how is that applicable in the real world? So a typical IV bag has how many milliliters in it?
So you can have 250, 500, or 1,000 cc's. That's how it's usually, you know.
Very good. So that means it's either a quarter, 1,000 cc's would be the equivalent of a what volume liter,
About a liter.
a cubic liter.
Yeah,
So
a
the
little more than a liter. Yeah.
so they come in quarter liter, half liter, and a full liter.
There's also 100 cc bags too of certain things. Because again, these each and so how can I explain this? So what we're taught is that each bag, no matter what bag you have or what size, it's going to tell you what the volume is,
Hmm.
and it's going to tell you how much of that particular you got the substance and the substrate. I always forget the chemistry, but the medication that's in there, if it's ringers, it's going to tell you how much of the solution is in there. If it's dextrose, it's going to tell you how much of the sugar is in there. If it's normal saline, it's going to tell you what the concentration is. Because so in that volume, it gives you the concentration of whatever it is that's in there. It's going to give you the total volume, and then it's going to tell you it's this and that, and what the concentration is of that particular thing. Because you could give you have if you just replacing volume, you might give 1 or 2 liters of normal saline. Okay. And that's because the lactose and the normal saline is going to react differently depending on what the person needs the volume for. So
what's the difference between substance and substrate?
Well, no, okay, so that was a term that I learned in chemistry. So now, okay, so here's the thing. I always get this confused, okay? And when I was taking chemistry, the thing of it is that water, which is the maximum amount, is always considered. I'm sorry, I said what did I say? I said substrate and
substance and substrate.
The 2 terms I should have meant was substrate and solvent. That's the 2. Because the solvent is not substance. The substance could be anything. So it's solvent and substrate. Usually, if I'm not correct, I think water is mainly the solvent, and the substrate is the thing that's in it.
Right.
And I've learned that in chemistry, not so much in paramedic school, but that's how I try to keep the thing together with what is. But in the terms of when I see, when I got my IV bags, everything is already, I don't have to mix anything. So I don't need to know what is. I just need to know, okay, I need to use this lactate ringers, or I need to use this normal saline. But in terms of the mixture or what, but it's good to know how those things are put together. So that's what I meant by that. I shouldn't have said substance and substrate. It should have been solvent.
No, you're fine. That's why we're here, so we can learn. I've learned a lot from you today. And I think that the solvent and substrate term with chemistry is a beautiful connection. I think that's what's important, is to make these connections so they can be standardized. Because
I need to add another one in there. It's solute. Yep.
Okay.
And for the person who has to take, the biochemistry is where this would come in. So when you take in, and some people in EMS may take that, if they plan on going to medical school, and all of the stuff that we learn, the math is in there. It's in there. It ain't going anywhere. But when you learn the terms, just like when you said milliliter and cc's is the same, because when I first got in this, I said, well, what's the difference between a cc and the ml? We didn't have Google during them times, so I had to dig deep. I had to dig deep, because they would, and depending on what you were reading, what you were studying, they would use those terms interchangeably. And I'm like, wait a minute, is this a CC or is this an M? Until I found out in a chemistry class, they are the same.
So IV bags are very commonly used.
Yes.
What are they the most used tool, or would you say syringes are the most used?
So day to day, particularly with trauma, both.
Got it. Okay. So what I think, can you think of any other tool that's used more than those on the day to day?
So the type of airway adjuncts you use now. Let me say this. Okay, so this is going to be something new to you too. So you have the different type of airway adjuncts, and these are pieces of equipment that assist a person in breathing. Okay, so you got the nasal cannula.
Can you type that in the chat?
Yep. Where am I? Let me see. Where do I have to go? Okay.
Just write it as number 8.
Oh, okay.
Because I've already done pain management as number 7.
Let me just categorize this. These things that I'm telling you now will fall under airway management.
Okay.
So should I put that on top of the 8?
Yeah, yes. That would be great.
And it's just to kind of keep it in perspective.
Hmm.
Oh, I didn't mean to hit it.
It's okay.
Okay. So uh you got nasal cannula, then you got non-rebreather. But um um what I should have put next to the nasal cannulas is a airway adjunct for airway management. Uh, so the same parentheses that I put around. I did the same thing again. So the same way I put airway adjunct for airway management in parentheses, that needs to go around, for nasal cannula. And if you want me to write it again.
Let me see. Give me 1 second. I'm
So now
creating.
so for nasal can, okay, so I missed an important part to put in here because each one of those take a certain percentage of oxygen, of which oxygen is a medication, believe it or not.
Hmm.
It's a medication. So with the nasal cannula, it has a range that the EMT learns to use, and it's anywhere from 2 to 6 liters of air because the oxygen tank
Hmm.
that is used, it has a percentage of oxygen that is released.
Hmm.
And for each airway adjunct that you use, you need to know what's the effective amount to use for the patient. So here's the deal. With the I'm just giving you an example. The patient who uses a nasal cannula.
Hmm.
So if you ever seen that patient with the 2 things in their nose and it's around their face,
Hmm. Hmm.
they hooked up to oxygen. That's a nasal cannula. So
Hmm.
that's giving them direct oxygen, but it's a low concentration.
Hmm.
And so you don't want to give them no more than 6. You might get away with 10. And so these numbers, the 2, 4, 6, 8, 10 is on the dial of the actual O2 tank where you control how much you're giving. So
What's an O2 tank?
oxygen tank, sorry.
Okay.
Okay, you seen the fire extinguishers?
Yep.
So just think about a green bottle that looks like that,
Hmm.
that has a dial on it. I can actually even pull up a picture to show you, but
Okay.
um let me do this here. Uh,
And what would you say this category is called again? You
airway
called it.
management. Airway management. Go here. Let me see this name. That's not what I want. All right, the slides go here.
Is this part of their curriculum?
Yeah, I'm
Oh,
trying to get to the, this is showing the pathophysiology, but I'm trying to get to show you what that nasal cannula and non-rebreather looks like and how they're giving it.
so
All right, so these are different type of airway adjuncts right here. So like this one is a suction. Both of these are, all three of these actually are suctions, just different type.
mhm,
And these containers is what will hold the fluid that you're suctioning out. So
mhm.
that's a form of measurement. And this is just, each one of them has a different capacity of how much that they hold. But that's not what I was trying. I just stopped there because we were there.
So you work live in the field right now, correct?
Oh yeah, yeah.
Okay, so if you could go back to those.
Oh, go back. Okay. Oh, what is this? Yeah.
Okay,
Mhm.
have you used any of those three items recently?
I haven't used them recently, but I've used them. It's like a bike. And
Okay.
I could answer any question you have about them.
Okay, so for number A, what is that and how is it used?
Okay, so it's a portable. All three of these are pretty much portable suction. Okay, and so you see the arrow.
Hmm.
So your hand would be right there. This is the container, and when you squeeze this device, this is the particular catheter that goes into the. Ah, I didn't mean to do that. Why
It's
did I?
okay.
Okay, this is the particular device that either goes, it goes into the mouth. And so
Hmm.
you measure this from the tip of this to the corner of the mouth to see how far do you want to stick this thing in.
Hmm.
The reason why that's the issue is because if you take your finger and stick it in somebody's mouth, they'll gag.
Right,
They
gag
gag, they're
reflex.
gonna aspirate. So you
Hmm.
don't want to go farther than that. The goal is to get whatever is loose in the mouth because they will aspirate on it. So this is a portable one that and this container right here will hold about maybe 50 cc's or something like that. This is
Hmm.
a smaller one. So if you just try and do something real quick and easy, use that. This one is on the unit.
So let
Okay.
me wait, well, let's before
Okay.
you move
Okay.
on.
Okay.
So this is called a suction.
It's a handheld, hand operated unit.
Okay, so it's a handheld operated
Mhm.
unit, but it's typically used for suction.
Yeah, it is suction. It's only
Okay.
used for suction. Yeah. Mhm.
So what it does, it sucks liquid or does it suck food or
It's okay. It really wants to get, if you have something that have chunks in it,
hmm
you're gonna use a wider catheter right here.
hmm
But you want to get fluid and you want to get chunks. You want to get whatever you can. All right. So just let's say that person if they vomit, if you know they vomit, you're gonna have some chunks in there.
hmm
So you need a wider catheter to get that out.
So
Um,
it's to get out of their esophagus or is it to get out of their their airways or
airway.
got it.
Yeah. Because if you esophagus, you're going too deep for this type of thing. There are things that you could, because the esophagus goes to the stomach, but that's in a control setting where they're sticking something way down into the stomach to get stuff out. That's not what this is. This is for the upper airway, clearing the upper airway so that it doesn't go down the trachea. You want it to go down the esophagus and stay down there. But if the person gets agitated, what's in the stomach comes up, and it comes up and it may come out of the mouth, but it may also go down the trachea too. That's a problem.
Got it. So because it's obstructing the airway.
Because it's obstructing the airway. Only thing that's supposed to go in the trachea is air.
Got
no
it.
food, no liquids.
Okay, great. So that container is not to administer air. That container is to hold whatever volume is taken from the body.
That's correct.
Ideally,
That's
the
correct.
trachea.
That's correct. That's correct. Because you are actually pulling stuff out with this. When you squeeze this, you are pulling out the fluid and whatever it is, you pulling it out.
Okay, so how is measurement used for suctioning devices?
Well, okay, so for this one, okay, the measurement is you want to take, you see the length of this tube right here?
Mm-hmm.
So this end of it, this tip, okay, you would put it to the corner before you put it insert in the patient. You put this tip, this is just for measurement purposes outside the patient, and it may be a diagram to show you, but you take this tip and you put it to the earlobe. So imagine this tip to your earlobe, right?
Mm-hmm.
From the earlobe, and then you want to see at what point does this reach your mouth, the corner of your mouth.
Mm-hmm.
So from here, from your earlobe to the corner of the patient's mouth, that's what you're measuring.
Mm-hmm.
And this mark right here will tell you how far. You don't want to go deeper than this into their mouth to suction.
Mm-hmm.
Because if you do, you're gonna disturb the gag reflex, which is gonna make a bad situation worse.
Okay.
Yeah.
Is there any need to measure the volume of air or either the volume of liquid?
What you're doing is you want to measure the amount of time that you suction. You don't want to take more than 15 seconds if it's a medical patient, and no more than 10 seconds if it's a trauma patient, because when you are suctioning, mm-hmm. you're also pulling out air. So that was a great question.
Mm-hmm. What's the difference between a trauma patient and a medical patient?
The trauma patient tends to lose more blood. A medical patient may be someone that has an internal thing, and it may not involve any bleeding at all.
Got it.
And so the problem with the trauma patient is that once your whole circulatory system has been impacted by some, by some injury that you either, a stab or a laceration, a puncture, you're mm-hmm. losing volume. And the problem is, if you're losing volume, the cardiac output of your heart is going to also be disrupted. Mm-hmm. If you disrupt that, then everything else is like a domino effect.
Got it.
So that's why you gotta call that in, and you gotta, get to the hospital as soon as you can while you're trying to stop the bleeding.
Okay, so for suction, typically what you have to concentrate on is aspiration prevention by the length of the catheter mm-hmm. and entering into the mouth. Mm-hmm. And the other measurement that you need to be cognizant of is the measurement of time.
Right. Based on medical or trauma patient.
Correct. Which meaning you should not administer suction more than 10 seconds on a trauma patient and 15 seconds on a medical patient. Mm-hmm. Now, when you're saying 15 seconds, are you saying total or are you saying per suction?
Per suction.
Got it. Got it. So you can have a series of suctions.
Yep.
You just want to make sure that the duration of each suction does not exceed a certain time limit.
Right, because it's like that. This container is number one. It's going to fill up. So you suction, boom, dump it. Suction, boom, come in. Suction, boom. When it gets filled up, you change this to another one. Because if if you're in a spot where you have this, and you change it over. But the idea is that the goal is to get that fluid out, but you got to be cognizant of how much suction you're doing.
Got it.
Mm-hmm. And see, the reality is, for real, when you suction in a patient, you're trying to get that stuff out, and you may not remember that 10 or that 15 seconds, but it's going to be coming up so fast that, you know, your goal is to clear that airway. But don't spend like 10 minutes suctioning a patient. You know what I'm saying?
Right.
Because you're taking away their oxygen. And at the same time, you have a pulse ox on their finger. And the pulse ox, which is
Could you type that in the chat,
I know
please?
I was getting ready to go over there. I was
Mm-hmm.
getting ready to go over there. Pulse oximeter, and then it may be pulse oximetry. I spell in two separate words. Okay. The pulse, it's the measurement of oxygen.
Are you still there?
Yeah, I'm here. I'm typing.
Okay.
Measurement of oxygen. Yeah, I'm oh, you might not see me. I'm typing in the chat.
Got it.
Pulse oximeter, measurement of oxygen in the blood.
And that's and they can you can tell that by a probe that's been injected into the finger.
It's not, it's not injected, it's just placed.
And it can tell how much oxygen is in the blood. That's
Yeah.
impressive.
Oh, it's supposed to be blood. I'm sorry. It says blues.
No,
Blood.
that's okay. It's a typo. It's
Yeah.
fine. It's fine. I know what you mean.
Yeah. And so that's a mathematical thing as well. I mean, what I'm saying is that it's done because it you put the device on the finger, and through a laser type of light, it's looking at how much it's doing the measurement of oxygen in your blood. So it's a
So
calculation.
so the oximeter is used very often.
Yes.
Got it.
Yes. It's
So
oximeter.
so the suction is used occasionally based on a basic case-to-case scenario, but it can be easily argued that an IV bag, syringe, and oximeter are used daily.
Oximeter, out of all of those, the oximeter is used daily. IV
Hmm.
bag and syringe is not necessarily used daily. I mean, mainly your trauma patient, but I'm saying pulse oximeter, it goes hand in hand with taking their blood pressure, taking your respirations, and checking your pulse and the temperature.
Well,
So,
oximeter does all of that, so you don't even need a thermometer anymore.
oh no. Pulse oximeter doesn't necessarily take your temperature.
Okay.
It just measures how much oxygen is in your system. At the same time, it may calculate your heart rate as well. I'll show you one. There's one in here so you can see it. You've probably seen it like, oh, that's what that is. So they just put on your finger and you sit there and the numbers pop up.
Mm-hmm. Is that
And
the thing?
so,
Is that the thing that? Well, that's your heartbeat. That's the heartbeat I'm thinking about.
yeah,
So
but it measures that too. So it has one line. Some of them has both the heart rate and the
mm-hmm.
pulse oximeter,
Mm-hmm.
and let you know 94%. If you got at least 94%, you're good. Anything other than that, the patient is having a problem with oxygen, whether it's because of a medical condition or a trauma condition. That it doesn't matter.
Mm-hmm.
It's going to measure the oxygen level,
Mm-hmm.
and so that's one of the things that, you know, it's a tool that's a must have in terms of your patient assessment.
And it's called it's pulse oximeter.
Yeah, pulse oximeter.
Oximeter.
Eh,
Oximeter, oximeter, oximeter,
yeah, it's usually pulse oximeter. Pulse
oximeter.
oximeter. Yeah.
Yeah, I'll get it.
You get oximeter. That's how you
Oximeter.
said. Yeah.
Good job.
Yeah.
Oximeter.
There you go. That's it. Pulse
So it's a pulse
oximeter.
oximeter.
Yeah.
And rooted in the word oxy, meaning oxygen, and meter, meaning measure. So
Yep.
oximeter. So it's
Measuring the
measuring
oxygen.
oxygen.
That's exactly what it's doing.
Got it. Okay. So the pulse oximeter.
And it's
All right.
done
Well,
by,
that was a sleeper. So the pulse oximeter does not typically require calculation because it doesn't. Well, it does.
yeah,
Well,
it's telling you that you got 94%. The numbers would show up. And so you're going to get, and you could get a percentage. You're getting a percentage of how much oxygen is being detected in the blood.
So if a person was supposed to be at, you said 94%, correct? And
Uh-huh.
they're at 86, then that means you need to take out the oxygen tank and you need to administer oxygen to get
And
their
if they're at
oxygen.
86, you probably gonna be doing CPR.
Wow. Let's say so 90 then. If they're at 90,
Yeah, they that's not good. They're going down to two. You need to be checking something. They definitely got to be on O2.
got
Okay,
it.
so O2 meaning oxygen. So
Got
we
it.
and so and that's the difference between using a nasal cannula and a non-rebreather, which is what we were talking about before for airway management. If their pulse ox is less than 90, you know you want to have a non-rebreather because the non-rebreather has a bag attached that collects oxygen so that you have closer to 100% more oxygen than if you didn't have the non-rebreather because the nasal cannula is just going through the nose.
So you know it would be very helpful because the diagram of the
Yep.
suctioning tool
Mhm.
was very helpful. And I think the airway management tools for me to actually see them would be
That's what I
very
was. That's
helpful.
where I was heading. That's where I was
Got
heading.
it, got it, got it. But before we
And
go there, just
mhm.
before we go there right quick. So in a nutshell, I'm not going to ask you to go into detail about these three suctioning devices. I'm just going to assume that they serve the same purpose with the exception that they can hold different levels of volume.
There you go.
Got it.
That's it. That's exactly it.
Okay.
That's exactly it. And you see right here, you see that he has this is a it's called the hard tip tube,
Mm-hmm.
and he has it in his hand. So
Mm,
this, as opposed to that, is a different type of. This is a little bit more. This one over here for the hand operated one is more flexible than this. This one is sturdy. So this one, you would use this to get your like chunks. This will more suction out chunks and stuff like. You have different sizes of this as well.
got it.
Okay. And
Perfect.
then this is the same thing. So this tube is soft like that tube, but
Mm-hmm.
the difference is and the container is in here. I mean, I'm sorry, the container is right here. And
Got it.
this one you got the little motor over here, so you could take this with you. There's a
Mm-hmm.
battery. This one is battery, and all of the stuff gets suctioned right there. So boom. So yeah.
Perfect.
So what
Okay.
you said is exactly right.
Okay. I've learned a lot today. This is awesome.
Okay, so let me just try to. I'm trying to get to the nasal cannula and non-rebreather because that's going to make more sense to you. They have some pretty good. I don't. Can I do that function thing with this too? I don't even know. Oh, okay.
Control
Let me go back.
Control F. You can try Control F.
So this one is a non-rebreather mask. So if you can see right here, this is not a good picture, but do you see that this is the part that would go over the face right here,
Mm-hmm.
and then this goes around the head. This green string goes around the head,
Okay.
and then this bag right here is what holds the oxygen.
Mm-hmm.
And then this is the tube that's leading to the oxygen tank. So remember I
Mm-hmm.
said that if you know what the fire extinguisher look like, it's the same type of container, but it's green and it has a little like they call it the connection looks like a Christmas tree, and you connect this to the end, you open it up so the air flows in here, it comes down, fills this bag up, and then the patient is inhaling closer to 100% more oxygen.
Wow.
Okay, and so for that patient, that the one that you said, if their pulse oximeter is like 90% or less than 94,
Mm-hmm.
if it's 94 and they are speaking okay, they don't sound confused, you can start out with a nasal cannula. But
Mm-hmm.
if it's like 90, you're gonna put this on.
Got it.
Now this is the nasal cannula. You see these two prongs right here?
Mm-hmm.
This is what goes into the nose. So this is direct. So with
Mm-hmm.
this particular one, okay, you're connecting same connection right here, but this goes in the nose, and these two pieces right here just goes around the face to hold it in place. Around the ears, you hold it in place. You don't want to put more than 6 liters because it's like if it's like somebody takes a what's the thing you pump basketballs up with?
Yeah. A basketball pump.
Yeah, so if you take a pump and you put that up somebody's nose, that's going to give you a rush, right?
Right.
But if you put too many liters, if you put more than 6 liters of oxygen in this thing, it's going to give them too much of a rush. So even when you put this on, you connect this first, you turn it on, and while it's on, then you apply it to the patient. You don't put it in the nose and then turn it on. And you see right here, you give 1 to 6 liters per minute. That's the measurement for the nasal cannula.
Got it.
And the amount of oxygen that's being provided is between 24% and 44% for this. Okay. And go back with the yeah, so this one, with this non-rebreather, you're gonna go all the way up to 15%. It doesn't say it here, but you're gonna go to the maximum that the leader flow will give you. We should have a picture of that in here too. So let me see. So okay, so now this right here is called your venturi. Okay, so this is for like you may have a person that's they may have a chronic lung disease. Right. And so if a person have what they call COPD, chronic obstructive pulmonary disease, if they have that you have to be careful how much oxygen you give them, because these are people who've been smoking all their life, whatever. And now, if you give them too much oxygen, it may shut down their lungs, believe it or not.
Wow.
So these different colors, the purpose of these different colors is just regulates how much oxygen is being provided. And these little tips go at the bottom right here. So that this goes on the nose, around the head, and And
the color code indicates what level of volume.
Yes, correct. And it says it on it. It tells them.
Do you know by heart by any chance?
Well, 24 to 40%. It's right here.
Okay, so we will have to specify which one is which.
Yeah, it's a standard though. It's standard. Each one of them is standard. In other words, the yellow's only going to be 40%, and this one's going to, what I'm saying? It's on there, but it's a standard. So it's not something where industry made it a standard, so you don't have to try to guess.
Got it.
Yeah. So this is a trachea, whole different phenomenon, but instead, so okay, your airway starts up here and it goes all the way down, right? So this person, for whatever reason, they have some sort of problem where they can't breathe through here, so now they can only breathe through their neck.
Got it.
And this is a tracheostomy that the patient have, and this is a mask for the tracheostomy so that they can get their air, they can get their oxygen.
Got it.
So they don't breathe through their nose, they breathe through their mouth. I'm trying to get to the. So this is okay. All right. So let me tell you the story about this bag. This is called a bag, valve, and a mask. The valve is actually in here, BVM for short. It's also called an ambu bag, but ambu is really just the name of a company that was able to, benchmark their trade. Just like, how you got a copy machine and a Xerox machine. Can you Xerox this paper for me? And Xerox is the name of a company because you really copying the paper.
Right.
So it's the same type of thing. So as you see right here, this bag valve mask is connected to your O2. So your O2 is this particular. Oh, I did that again. How do I do that? It's connected to the oxygen tank. This bag fills up with oxygen. This is the bag that you squeeze this on the patient's face, and this is when you deliver 100% oxygen. Okay, so that's where the math comes in with this, is that you learn that you get a high percentage of oxygen when you use this BVM connected to this bag valve mask that is actually connected to an O2 source. Because you can use this without this connected. But if you use this, you're only getting atmospheric air.
Okay, so that's atmospheric air. It's not from a tank.
That's if it's not connected.
Got
Once
it.
this is connected, it's 100%.
Got it. But if it's not connected, it's still effective in helping the patient get oxygen.
Right.
It's just atmospheric oxygen.
Correct.
Is it an increase in the level of oxygen from the atmosphere?
And no, it's a decrease from the atmosphere, because clearly we only have like 21% oxygen in the atmosphere, believe it or not. Yep. We got other stuff. We got other stuff in there, but it's only like 21%.
Oxygen.
Yep.
That was very insightful. I had no idea.
Yeah, and that's why when this is connected, you're getting 100%
100%
because
oxygen.
yeah, and see the surprising thing is that for us to be able to breathe, that's all we really kind of need. You know, you see what I'm saying? Our body can function on that. So we think, oh man, I need more oxygen. Yeah, you need more up to 21%. But if there's a problem, you need to be able to give that more because now you're trying to force this blood into the system to do what the body normally does on its own. Now you have to mechanically induce it so that it can get through all the vital organs, your
That's
brain, your lungs, your heart.
very insightful.
This is all part of airway management. So the air, okay, so now, all right, so this is CPAP. So CPAP, you see this person right here. This is a device that's on their face. So this person can breathe, all right? But let me put it this way. Okay, you know people that snore? All right, this usually helps them to better oxygenate their system or to help them relieve them from snoring. Because you know when you snore, you're actually not really breathing for real.
I didn't know that.
Yeah. And sometimes people wake up and they're catching their breath because and it's a it's a serious thing. But so what this does is a what they call non-invasive means it's a way that you're giving support to somebody breathing because they consider snoring is a sort of distress for your respiratory system. But you're giving assistance or support to breathing for someone who has the capacity to breathe, and it just with the seal on it, it just forces that air to go in the way it's supposed to go. And so and it the sleep apnea is actually assessed with I shouldn't say everybody, but when you have sleep apnea, this is what's going to help them.
Can I ask a quick question? Because we're gonna have to start wrapping it up in a second. For your first quarter, are you doing airway management or are you doing like for the course?
We would actually Julius Jackson and I was just talking about that because what I told him was this. Here's what our situation is. We have a different style of teaching, and I told him, I said we have to give them more hands-on and understanding of what they're doing, and I want to start with the difficult stuff in mind.
Okay.
And so with one of the things we're going to do, CPR is a prerequisite, but we're breaking it up into sections. And airway management is one of the most important things that you could do for any patient.
Yeah, because what a lot of people don't know is like if you ask somebody if they had to go with one major element for an extended period of time, what would it be? And a lot of people say, well, I'd rather go without food than water, or I'd rather have water but no food. But you can live days without food or water, but you can't live minutes without air.
That's right.
You can't make it an hour without air.
You can't make it 4 to 6 minutes. After 4 minutes, you're in trouble.
Right, exactly. So yeah, airway management is very important. I think it's undervalued and not recognized for its importance. But let me let you continue. I just wanted to
that's
support
important.
you.
Yeah, I'm gonna try to speed this up a little bit. I want you to see one of the oxygen tanks, but they should have one in there because you saw the nasal and you saw the so this is what the trachea looks like. That's the opening, and some people may have a temporary one, and some people may have a permanent one.
So in our future sessions, what I'm going to do is I'm going to have you give me the I'm going to have you giving me an intensive and an overview of a different concentration, um, so I can get a better conceptual understanding, especially with your diagrams. So I really would love for you to have like just your images and things together so you can just teach me. I think it would also be wise if we align what we study and what we start to prepare ahead of what is going to be taught in class.
Well, that was
So,
one of the things that I did with that modern classroom. That's exactly what I did because I was trying to figure out how to pull up that to show you each one of those things because I have the nasal cannula, the non-rebreather, I have it all separated, and then they
got it.
got a little quiz afterward. They have to tell me how much oxygen and what's the contraindication for it and all that kind of stuff. So yeah.
Okay, great. So do you know where that is right now? The modern, it's called the modern
Um
curriculum.
um So I submitted it in my this is terrible. I submitted it in my oh wait a minute, hold on. Wait a minute, 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 wait a minute. Hold on, hold on, hold on. Let me do a screen pal. Let me do this right here. Wait a minute, wait a minute. Oh man, which one of these is it on? Get out the way. Um or let me see. Hmm. Do this here. This doesn't have all the stuff on. I gotta go to the other account. Okay, let me go back. Go back again real quick. Oh, because I gotta log out of this first. All right. Ah, go to the app. Continue. Okay, here we go. Ha ha, here we go. Can you see this?
Yes, I can.
Okay, so let me give you an example about one of the things that let me see. Okay, okay. This is screen pal. Let's see. Okay. Trying to go to see a short one. All right, let me just see if I can do this right here.
A bag mask device helps in performing ventilations on patients that need assistance breathing or cannot breathe on their own. Prior to beginning patient care, be sure to employ appropriate body substance isolation procedures. Before opening the airway, consider the possibility of a cervical spine injury. If no spinal cord injury is suspected, open the patient's airway using the head tilt chin lift maneuver. If you suspect a spinal injury, use the jaw thrust maneuver. Masks should be chosen to fit the patient without air leakage, so make sure that you have the correct sized mask and bag for the patient. Attach the mask and the bag to the one-way valve.
That's the see the tank.
Oxygen
Yep.
slit.
See the bag filling up.
Create a proper mask to face seal. Begin ventilations as soon as the mask is sealed and assess for air leakage. Ventilate at the proper rate and volume for that patient. Pay close attention to ensure that each ventilation is of the appropriate volume and of a consistent rate. Allow adequate exhalation between each breath. Each ventilation should be delivered slowly and easily, lasting 1 full second. For bag mask ventilation involving lung rescue, use the C-clamp hold.
See how the bag is filled up with the air at the end?
And that's coming directly
Breathing
from
is
the tank.
compromised or the patient is unconscious. Consider using an oral.
Say it again.
And that was coming directly from the tank.
Correct.
Okay.
And so now these two things that they're using, this one is a nasopharyngeal airway and this was an oropharyngeal airway. And you would insert this in the patient before you use the bag valve mask. So I have a separate one where you show how you do this by itself and this by itself. This is just combining all three.
But typically you would want to turn the air on before, you insert.
So, okay, you haven't hooked up to your adjunct, and the answer is yes. So with the non-rebreather, you watch the bag fill up. You have to put your finger and watch the bag fill up, which I have a thing on that. And the nasal cannula, the issue with that is you just don't want that rush. It's nothing to look to fill up, but you don't want that rush.
Got it.
And with this, the bag is filling up as well. Yes.
Nasopharyngeal airway device.
Yeah. Now, ultimately, I want us to be able to be demonstrating, but because I was doing this class, I had to do stuff quick. So I just, pulled what I had.
No, that's awesome.
Yeah.
So this is what the learners watched.
Yep. This is a new thing for them. It's going to be a new thing for them. So they're going to have these little short snippets of each one of these things. Okay. So watch this one. Okay. Let me just show you this real quick. Because this one.
Could you copy and paste that link and put it in the chat so I can have access to it too?
This is an actual, how do I do this? This is, I should be able to do that. Cause I did this on ScreenPal.
Okay, so this is a video presentation that you put together.
I put this together, yeah.
Okay, and it's currently on a platform called ScreenPal.
No, ScreenPal is the platform that I put it on. This came from, you saw that other thing I was with in JB Learning. This came from that. It's part of the learning management system.
Got it.
So this one is just going to show you real quick.
An EMT must be able to administer oxygen appropriately to a patient. Oxygen cylinders are usually green, white, or chrome. Make sure to confirm the presence of an O-ring. Then carefully attach the regulator and secure it tightly by hand. With the face of the gauges pointing away from people, open the cylinder. Open and close the valve quickly to blow out debris. Be sure to check the tank.
Just so you know, each one of these is a step. Okay. So there's a checkoff sheet. So first thing is cracking the bottle. Then you put it on. They got to know what their gauge is. They need to know if it's a leak. They need to be able to check for that little washer in there. And they're going to watch the needle on that thing. I'm just,
The pressure is measured in pounds per square inch, or PSI. It is important to read the pressure accurately to within 100 PSI.
He turned it for life. Attach
the oxygen connector tubing to the flow meter and ensure that oxygen is flowing through the delivery device. When the reservoir bag is full, administer the oxygen to the patient at a rate of 10 to 15 liters per minute when using a non-rebreathing mask.
Boom. Yep. So now, what I love about this is that if I do this skill and somebody's not there, they got this and they can look at it again.
Right.
So now that was the oxygen. Oh, that was the oxygen tank. So yeah, so that's what all of these are. So that, yeah, so
Okay, so starting on the 28th, which is only 6 days from now, which wait a minute, what is that, a Monday? Is the 28th a Monday?
yeah, I think so.
What what are the learners going to learn the first month of the school year starting in September?
So ultimately, that's going to be Jackson's decision. But I said to him, I want to start with this. You see this right here? You see this section is basic BLS resuscitation.
Mm-hmm.
All right, so that's literally CPR, right?
Mm-hmm.
But CPR can normally be taught in like a few hours, but because these folks have to be expert, I want us to stretch it out so that we're starting with the management of the airway and understanding.
Mm,
You understand what
got
I'm saying?
it. Conceptual understanding. Yes.
Yes. And that's going to take knowing how the blood flows through the heart, through the lungs, to the brains, why it's important, and the concentration of oxygen management and knowing how much to deliver.
So that means that you'd like to focus on the oximeter and oxygen tank and
Yes.
the
Or,
what's the
or yes, all of those come into play. And because yeah, they may or may not have taken CPR before, but then to understand the mechanics of it, to know, because people forget, people take CPR and they forget.
yeah. And how long are you going to be studying? Would you like to study airway management for 1 month, 2 months, three?
Yeah, we probably need to do it at least about a month, because the one thing I hate is that we have an hour and a half each day.
Mm-hmm.
And that's prior to that, we would have maybe 3 to 4 hours consecutive. I mean, same amount of time, but when it's together, you could get more done. So breaking it up this way, that's the only positive about it. But I would say about a month.
Okay, what would you study? What would you like to study after airway management?
What we're going to do is take the whole CPR component and break it down. Airway management, circulation of the blood in the heart, chest compressions. Okay, breaking down the parts of CPR.
Got it. Let me see. Where is that chat? On. So
So I kind of want to start with the end in mind. And Jackson pretty much, he said, okay, he's um
what would you study in November?
see, all of these things are sequenced. Let me see. Let me see. Patient assessment. So yeah, so this is another thing that's going to be okay. So let me say it this way. Patient assessment. When we're doing the airway management, when you're confronted with a patient, you have to assess them a certain way. There are actual steps of how you need to approach that patient that they need to understand with the medical patient versus the trauma patient. Once you identify what it is, you're gonna be doing just a few things a little bit different. Because of the nature of the illness, because whether it's medical or trauma, they could be a stable medical or unstable medical, or they could be a stable trauma or unstable trauma.
Mm-hmm.
So stable would mean that, oh, I got my finger cut and I'm just bleeding out a little bit, control. So it's, you know, that's a medical thing, but it's no big deal. Okay, got my foot cut off. That's major.
Right.
Unstable. Okay.
Right.
And you're gonna treat them a little bit different. But the idea is stop the bleeding, but you still have to, because the foot is cut off, you still have to pay attention. Are they breathing? If you can save that foot, and if you didn't help them to breathe because they're in cardiac arrest, then you saved the foot, but you still got a dead patient.
Right.
So I could show you what a schedule may look like. You know what I'm saying? That you could have a format, because the way that the book is written, we may not necessarily go in that direction, but it's going to be a flow in terms of them to build on the understanding of what they're doing.
Right. So if we could kind of zero in on the sequential delivery of the content,
Yeah,
that would help us align
the math part
the
of it.
math enrichment
Yeah.
to that concentration. And we can get more specific in our next session, but it would really help us out to know like what is expected to be studied in the month of September, what's expected to be studied in the month of October. And as long as we stay about 3 months ahead, then that'll be fine. What other than airway management, circulation, what would be the next area of study?
Well, patient assessment as a whole is broken down into like 50 different parts.
Got
So
it.
once you do the anatomy and physiology, the airway management, and then you get specific in the CPR, but then you're doing these separate things, but then you're learning, okay, you have these categories of patients that you're going to take care of. And the category is going to be, is this medical, is it trauma, or is it rapid or not rapid? You know what I'm saying? So it's a sequence. Once I show you that, you'll see what I mean. But I mean, I know we got to go now, but
No.
I'll
I'm
keep
just
I'll give you a roadmap so that you have a better understanding. Because
right.
because I'm gonna look at you like I'm looking at one of the EMT students that's coming in and trying to understand this and make sure that they're comfortable with the flow.
Right. So here's all I'm trying to get a general overview of. Okay. And it could be very general. I just want us to kind of make sure we are aligned. Patient assessment seems like it has a lot to do with everywhere from medical, rapid, trauma.
Yep.
And so patient assessment is something that I definitely want to learn more about, and especially when it comes to the measurement or the math related to patient assessment. But when it comes to what is it called when you go beyond assessment and you actually start intervening and applying life-saving techniques? Like with airway management, you have to apply techniques to save.
All of those techniques are based on your patient assessment.
Got it. Okay, so patient assessment is the top, and then there are categories under the patient assessment.
Yep.
Okay, great. So what are those different categories in the patient assessment?
You have the medical and the trauma. It's for real. It's only two. Only two. And then it's stable and unstable for medical and stable and unstable for trauma. And I always bring that out because it seems like, oh my God, there's a whole bunch of stuff. Now, then you break it down to adult, child, infant, and pregnant. You know what I'm saying? But the categories are still going to be medical or trauma. There's only two categories.
So what's rapid?
Rapid is that if you have that unstable patient, you're not going to stay and play. You're gonna just look and see, do they have a pulse? Are they breathing? And then you're going to package them to go. You're not going to stay and say, okay, let me take a blood pressure. You're going to wait till you get on the unit to physically take. You just want to know, am I feeling a pulse? Okay, I got one. Let's package them up.
Got it.
You don't have time to play because they bleeding out. You wanna do everything you can to stop the bleeding. you know, or if they're having trouble breathing, if somebody with asthma, you give them the albuterol right then and there. And if they don't get better, you know, you let that while you give them the medication, you packaging them up because you see that they're going down the tubes based on, you see the diaphoresis, the trouble breathing, the chest pain, and you're looking at the monitor, the EKG. All of these things are indications of whether you're going to do rapid or not.
Okay, so what's a monitor in EKG?
The monitor is that when you put the leads on and you look at the patient's heart, and and the EKG is the picture of the heart. You know that paper that when you go to if you go to the doctor and they put those stickies on you and they say, let me look at your heart. So the monitor is a quick way. We got a 3 lead, we put it on the patient and we take a look. And now the EMTs don't do this, but we teach them what the paramedics do so that they could be familiar with that process. Because you do pair up EMTs with paramedics these days. So you want them familiar with what a monitor is and what an EKG is. Familiarity with it.
So the monitor and EKG are related to circulation.
The monitor and EKG is related to the heart. And circulation as it relates to a heart, but it lets you know what the heart is doing. It can tell you what the respirations are, and it could also let you know how much oxygen the patient has. So you're actually looking at a whole monitor. The monitor has different parameters on it. You got the EKG reading, the capnography reading, which is letting you know how much CO2 that you're exhaling out, because it's supposed to be a balance. Okay. That range is supposed to be between 35 and 45. And so you get numbers on your monitor. It could be too low, it could be too high. Depending on how the patient is presented, you have an idea what you got to do. And of course, the blood pressure. And then, of course, the respirations, all of these things. And that's why it's called.
So wait a minute, is the blood pressure, and you said after blood pressure, what? You just said respiration?
Yeah, blood pressure, respirations, pulse oximetry is on there too, because that is connected to that. And the carbon dioxide, CO2.
That's all on the EKG monitor.
It's it's monitors. The name EKG is one of those performances that the monitor does.
So it's a circulation monitor.
It's not called the circulation monitor. It's called the monitor, right?
Got it.
But the things it's monitoring your blood pressure, it's monitoring your pulse oximetry, it's monitoring your CO2, and it's monitoring your EKG.
What's EKG?
The tracings of the heart.
Your heartbeat. I'm trying to simplify it. No, I want you to go into detail. What is
okay.
What does it stand for?
Electrocardiograph, and that K is German for cardiograph.
Got it. Electrocardiograph. What's the G?
Graph.
Oh, so electric cardiograph. Okay.
Yeah.
The electric cardio heart graph.
Yeah. So it's gonna be ECG or EKG. The K and the C. The K is the German, but you say if a ECG, okay, it's when you say ECG, that's English, electrocardiograph. But it was mainly known as the EKG, which is still electrocardiograph, but the K is just German.
Okay.
So electrical graph of the heart. So it's electrocardiograph, electrical heart graph. And those, because you got those leads on it, and the heart is electrical, so you're measuring the electrical activity of the heart.
Got it. This is very insightful. Okay. We could do a spiral approach.
the hard part will be the fun. Now they don't typically do EKGs, but when you look at, I'll say this because you're a mathematician. So you know what an EKG paper looks like? It has those little boxes on them.
I will need to see it.
Oh, okay. Let me just see something here real quick. So this is, let me see. All right. Haha. Can you see that?
Mm-hmm.
Okay. So let's look at this one right here. Let's look at this one right here in a minute. Okay.
Okay.
All right. So now, okay. Forget the black lines for a minute, right?
Mm-hmm.
You see the heavy, if I move, this is going to move this thing, but I don't know what to, okay. How can I, maybe if I click it? Ah, yeah, here we go. Here we go.
Mm-hmm. Mm-hmm.
Yeah. So you see these heavy lines right here, right? See how I'm
Mm-hmm.
doing this? Like this is a square, right?
Mm-hmm.
Each one of these squares, okay, has a measurement.
Mm-hmm.
And it's 0.02, 0.02. Wait, I'm saying that wrong. 0.04. Each one of these is 0.04.
Mm-hmm.
So
So it's 2, 4, 6,
0.04.
8,
Mm-hmm.
10.
It's five of them. 1, 2, 3, 4, 5.
Right.
At 0.04,
Mm-hmm.
right? It should come out to 0.20, right?
Mm-hmm.
All right. So now, what's the significance of that? The significance of that compared to this line right here, right? So let's look at, again, you see the box in here? You see this box? You see
That
me?
represents, if each one of the smaller boxes represent 2, then that is a
Each, each, each,
0.02.
each smaller box represents 0.02.
Okay,
Yeah.
cool.
All right. So now, and that's 1, 2, 3, 4. These are the 5 boxes, right? You see?
Right.
All right. All right. So now, do you see this space right here where I'm
Mm-hmm.
pointing?
Mm-hmm.
This is considered a PR interval. So this is the P and that's the R. And this is the space between this beat and that beat. Because these wave points are heartbeats.
Mm-hmm.
Okay. So this, I should say, this right here, contraction. This right here is letting you know that the ventricles are working. Sorry. This right here is letting you know that the atriums are working, which is the 2 top parts of the heart. And this right here lets you know that the ventricles are working. This QRS, when you see this tracing, oh, okay, you got a P wave. Well, that's cool. You got a QRS. And so it got its name just like our parents gave us our name. They just said, okay, we're going to name you Doreen. They saw this wave. They said, we're going to call this P.
Mm-hmm.
And they saw this one, we're going to call this Q. And this one up here, we're going to call this R. We're going to call this S. And then when it starts again, we're going to call this a T wave. So now we go back, we got another P, Q, R, S, and then a T.
Mm-hmm.
So now, having said that, this space right here in between, okay, what they use this graph for is to show how many seconds did it take for this particular contraction to happen between the P and the QRS.
Mm-hmm.
So now, here's what happened. This is a standard, okay? This is a PR interval. If the PR interval is 0.20 or less, it's normal. Because that means that it's not greater than 5 of these boxes.
Mm-hmm.
Right? And so when the cardiologist looks at it, they say, oh, okay, so the contraction of the atriums to the ventricle is in the normal realm. The reason why it's important is because if this, so it's the same thing for all these other wavelengths that we see, they have a meaning. Okay, so they're measured by how many boxes that you see in between there. So now, sticking with this P to the Q,
Mm-hmm.
We could have a situation where I wish I could make a line. Can I make a line somewhere? Anyway, if the P wave was over here and it came all the way over here, then we had QRS, we got 1, 2, 3, 4, 5 boxes, right?
Mm-hmm.
So that PR interval would be greater than 0.20.
Mm-hmm.
So that means that this person's heart has a delay for whatever reason.
Mm-hmm.
There's a delay in the contractions of the atrium to the ventricles based on this line.
Got it.
So there is a heart condition that's called first degree. It's just a name, but it means that the PR interval, okay, is greater than 0.20, but it's constant. So it means that every time you see a PR interval is greater than 5 of these boxes, okay, but it's the same. So this PR interval is the same. The one over here is the same. The next one over here is going to be the same, but they're all stretched out over 5 of these.
Mm-hmm.
That's called first degree AV block. So why they call it AV block? The AV is the atriums and the ventricle. So the beats, the electrical current between the atriums, which is the heart, is a, the heart has, the heart has 4 chambers, right?
Mm-hmm.
And so let me see. And the heart has 4 chambers, okay? And so the atriums are up here and the ventricles are down here. But the pathway goes like this. You see how I'm going like up and down?
Mm-hmm.
The pathway goes this way. And so what is it saying is that when the electrical activity is going down this way, when it gets to this part right here, which is between the atriums and the ventricles, there's a block.
Mm-hmm.
And instead of it taking 0.20 or 0.20 seconds to go, it's taking a whole 0.20 seconds to get down there, and then it's going to contract.
Mm-hmm.
If that makes sense.
Yep.
Okay.
Mm-hmm.
So now, having said that, that's how you identify all the other rhythms. But before you can know what the others are, you have to get this down packed first. You got to know what normal look like. So this is a normal P wave. This is a normal QRS, and this QRS is, you see, it's just between 2 boxes.
Mm-hmm.
So that's 0.04 plus 0.04. Okay.
Mm-hmm.
And this PR interval right here, is between this P wave and that. Okay, it's not greater than this whole thing, all right?
Mm-hmm.
And then this T wave is in between here. So then the heart resets and it starts again. PQRST, PQRST, PQRST. Now, if something happens and that heart, oh, I meant to do it a different way. I meant to do it a different way, but that's okay. I was just going to show, because you see, okay, so based on what we saw before and looking at this is messy, right? Mm-hmm. This is like, oh my God, what do we have here? Okay. Mm-hmm. So.
Yeah, it doesn't look normal.
It doesn't look normal because you already know what normal looks like. And you can't identify a P wave, you can identify a Q wave. So
QR.
And so the ventricles is the bottom part of the heart, and then tachy means the tachycardia, a fast heart. Tachy means fast, cardia means heart. And then the ventricle is just telling you where this rhythm is originating. So it's originating in the ventricle, and it's pretty fast. Okay, so ventricular tachycardia. And then this one right here is ventricular fibrillation. You can't make anything out. So the heart is fibrillated. It's not even beating. You don't see a P, you don't see a Q, R, S, or T. So it's not normal. Okay.
Yeah, it's just random.
It's random. And it's fibrillatory. So this person, right, anytime you see this, the person is not breathing, they don't have a pulse. They in cardiac arrest. This patient right here, so if we look, we see PQRST, right? PQRST, right? PQRST, right? PQRST. Then we see this. Okay, so we have a beat that is premature. because all of these others came, like you see the space between this, then you got this long space, but you got this beat right here that normally, if it was normal, it's going to be right here, but it came before. So they call this a premature ventricular contraction. It's coming before the normal beat. So this one right here kind of looks like this. So when it's wide like this, you know that it's originating from the what? Ventricle.
Yeah.
So it's called premature ventricular contraction. And you learn about the math of this comes in because tachy means fast, okay? Brady means slow. Fibrillation is going to always look like this, chaotic, okay? But it's all in reference to how does it fit on these lines, the EKG lines. So that, I mean, that was a kind of a crash course, but you know. The key thing is that knowing what normal versus abnormal. So you see all this other stuff, like, wait, the thing that's abnormal in this is this and that. Don't look like these. And the R to R gives you the rate. Okay. So you know that from here to there, from there to there, from there to there, it's usually 10 seconds. A 6-second strip give you 10 seconds. There's a whole, I'll pull up that. We'll do a whole math thing with that, because that right there, the math part of that is just, it'll blow your mind.
I'm excited.
Yeah, because you look up here, you see the rate between 100 and 250, QR complexes. So this is, again, so this is telling you, if you notice it's less than or equal to 0.12, how many squares is that? This is going to be 3 of those little squares, right? Because each one is
0.02.
Yep.
So that would be 6, right?
Wouldn't it be 2, 4, 6, 8, 10, 12? It'd be 3.
Okay, I'm confused because I thought each one of those little boxes was 0.02.
No,
so
okay.
No.
Each one is 0.04.
Oh, okay.
Yeah, each little box is 0.04.
Got it. I thought it was 0.02. So if it's
Yeah, no,
0.04, then 3 of those boxes would be 0.12.
Yeah.
Or 0.10 too, or 0.12, yeah.
Yeah. And
Okay.
so 5 of them will be 0.20, right?
Got it. Yes.
And so 5 is your magic number. Now this is the only time where I could skew out the numbers with it when it comes to this, right? Because of the EKG and having people to understand how. But I always start out with the simple stuff first. We build on this. I'm just giving you a crash thing. We building. But the main thing for you is that these numbers right here, okay? And so the rate of ventricular tachycardia, you know, it's going to be at least 100. So, but this rate is between 100 and 250. So anything, you know, when you count this, you know, that's the rate. And this is 100 to 250 beats per minute. And the rhythm is only regular because it looks the same. And the distance between is the same. You can't identify any P waves, okay? And there's no PR interval, because remember, PR interval is between here to here. If you can't identify the P, then you can't get the PR interval. So these boxes just give you a description of what that is, of what.
Where can I find this?
I just pulled this up. I just pulled this up. I did what did I do? I did let me go back. I put in the thing this thing up here. Okay, look up here. It says www.et.
Etsy. That's Etsy.
Yeah, and I didn't put that in. I originally put in show me EKG. So if you put show me EKG, you're gonna get a whole bunch of stuff. And then remember, I clicked on one. So let me go back and let me see. This is what I did. Yeah. Oh, this is not what I did. I didn't do this. Hold on. I'm trying to see if I could go back to. This is the one I clicked on. So if I go back from here, then maybe I can show you. This one. Show me a normal EKG strip. That's what I put in. You see it? I did that. And then I honed in on this one, I think. I honed in on one.
Got it.
Because it's sort of PQRST. So look at this right here. This right here. Here we go. Ah, this is
Mhm.
you right here, bro. It's you. This is it. This is it right here. This is what I was talking about. This is what I was talking about. The only thing this doesn't show, it doesn't, okay, so this doesn't show the small boxes,
Mhm.
but it does show that this is the time in seconds and this is in milliseconds, right?
Mhm.
This right here is showing what a so this will be this is a okay. The PR interval, okay, 0.16 seconds. So this should be what, 3 boxes, right? I mean, no, wait, what is 0.04
That's
divided?
4. That's 4
Yeah,
boxes.
so that's 4 boxes. So that
Mhm.
it's still based on the 0.20. They don't tell you that here, but that's
Is it
what
point two? Is it point zero
0.04,
four?
sorry,
Okay.
0.04. I keep
Mhm.
saying that. That's why I'm messing you up.
It's
It's
okay. I'll get it. I'll
yeah,
try to figure it out.
yeah, it's 0.04, and that's how that, but it's telling you that this right here is 0.6 because it's adding the 4 boxes.
Right.
Okay. All right. And so now this is a measurement of the PR interval.
Mhm.
Then you got the R to R. So the interval is just means the distance
Mhm.
between, and this is saying, so this is getting in time in seconds. So however many seconds, this is what? This is going to be 1 second, right?
Yep.
1.2 seconds.
Mhm.
All right. So now up here, this is just time. Remember I said that the P wave is the contraction of the atrium. So this is the atrium. This right here is what you're looking at, the measurement of what's happening with the atriums.
Mhm.
The QRS is the ventricles.
Okay.
It's what's happening with the ventricles. Then it's getting ready to start all over again with the P wave,
Mhm.
PQRST. All right.
Mhm.
And this is just showing you, it didn't show you the segment over here, but it's showing you the segment over here. And so from the
Mhm.
S, because remember, this is PQRST, from the S to the T, okay, you have what's called an ST segment.
Mhm.
All right. And then from the Q to the end of the T, because this is the T wave. So, but the measurement for the QT interval is from the beginning of the Q to the end of the T. And it's just giving you where those measurements are taken from.
Mhm.
If that makes sense.
Well, where the measurements are taken from.
Okay. When I say take it from, let me say different. I should
Mhm.
not take it from. I should not say take it from. I should say this. I should say, when you look at the EKG, let's go from stuff from here, and you see that you got a wavelength here. You got a P wave.
Mhm.
Then you have a Q down here. You have a S. I'm sorry, a Q, R up here, a S, and then a T.
Mhm.
What this is showing you, okay, is a contraction of the heart.
Mhm.
This P wave is just showing you for this segment right here, this is happening in the atriums.
Mhm.
So when you put that EKG on and you look at the strip and you see this up, that's a P wave. And then so you know that okay, the atriums are working. Then you see the Q, R, and the S. Oh, the ventricles are working. And then you see this wave right here. So okay, we're getting ready to start again. So
Mhm.
you got this distance between that R and that one. This is the difference between two contractions.
Mhm.
And in it, you look, here's another P. They don't have it labeled, but this is the P, right?
Mhm.
This is the Q. This is the R. This is the S. Then you got the T again.
Mhm.
All right. All right. So now, when I said, however I said it, I shouldn't have said it that way because it doesn't make sense saying it that way. This is an illustration of what is happening in terms of you seeing what does a contraction look like.
Mhm.
This
Visual
is what it looks like
representation.
electrically.
A visual representation of a heart contraction.
Yep.
Okay.
As it relates to the atrium and the ventricles contraction. Now, this will really have a whole lot more meaning to you if I were to do, if I were to show you the heart and show you how the electrical conduction system works, it would make much more sense. But just
Okay.
in terms of looking at this, I'm just saying, I'm just telling you what it is.
Mhm.
But if I were to do a class with students, I wouldn't start out with this. I start out with the heart first. I'm trying to see if I did that again. Let me go back. Keeps going back to this Etsy thing. I'm gonna put here, show me a picture of a heart. Let me just do this. Because there's a lot of math with the heart part.
Mm. So there's a lot of math with what we've just been studying on the EKG,
Oh yeah.
electrocardiograph.
Oh yeah.
I know what EKG means now.
Yep.
Electrocardiograph.
So I'm trying to think. Um, I'm gonna say, show me electrical conduction of the heart. Show me a. It's gonna make more sense when I show you this. The electrical conduction. Electrical conduction of the heart. Let's see. Let's see. Diagram, heart diagram. That's what I think. Here we go. Hi, here we go right here. This is a good one. This is a good one. It looks good. This looks good to me. Oh wait, where did it go? Okay. Now look at this.
Talk to me.
Okay. This is your pathway right here. This is the SA node. Okay, first of all, you got 1, 2, 3. These are your 4 chambers. These 2 up here, this area and that area, okay, is considered the atriums, right?
Mm-hmm.
This area and that area is considered your ventricles.
Okay.
So the electrical current that I'm talking about, I'm trying to see if there's a better picture down here. Hold on, wait a minute. Let me just move this out the way. Now I like this because it's got the EKG up here. So the electrical current, the electrical conduction that I'm talking about, the direction is going from this area called the AV node, sinoatrial node, which is in the right atrium. Okay.
Mm-hmm.
It comes down here, and this is where all 4 connects, all 4 of the quadrants connect, right? So you got your 2 atriums up here and your 2 ventricles. So you got the SA node and the AV node. So they call this area the atrioventricular node.
Mm-hmm.
Okay. Then from the AV node, it goes down to the right and left ventricle. Hold on a second. Okay, you there?
Yes, very much so.
Okay. So you follow me so far?
Mm-hmm.
All right. So is that the same one I got here? Yeah.
So
So
the atrium, the 2 atrium chambers, you have 2 atrium for chambers and you have 2 ventricle chambers.
yep. And it's a total of 4 chambers of the heart. 1, 2, and 3, and 4. However you want to number them, but there's 4.
Mm-hmm.
So if you look down at the bottom down here, this, you see this down here?
Mm-hmm.
These are the 4. It looks a little bit better. You can see the chambers a little bit better here. So that's
Mm-hmm.
1, 2, 3, and 4, right?
Mm-hmm.
Okay. So the reason why I like this is because it got this EKG up here. So that's what I'm going to show you.
Mm-hmm.
All right. So the direction is SA node to AV node. And then you got the right atrium and the left atrium. Now, this is the right side.
That's
And
the right ventricle.
This is the right, yeah, but
Okay.
yes, it's the right, this is the right ventricle, this is the right atrium. So, but this whole thing is the right side because you're always making reference to the patient's right. So when
Got
you
it.
look at, yeah, so that's why you see right over here and left over, and this side will be considered the left.
Got it.
Okay.
Because it's the patient laying on their back.
Or in front of you. They could be on
Right.
your back or in front of you.
Okay.
It's like you looking in front of them. So
Got
either
it.
way, yeah.
So it's always the patient's right.
Yep. It's always
Okay.
the patient, right? When you looking at them, or you're looking at a paper, or you're making a reference, you're always gonna make reference from the patient's right.
Got it.
Yeah. Okay, so electrical activity goes down here, and then when these contract, the way it looks on the piece of paper is this right here. So you see that dot is consistent with that, right? So electrical activity, when it gets here, boom, it's going to show that, right? When it gets down to here, all right, and when the ventricle contract, you're going to see this on the paper. The tracing is going to look like this, QRST. It's just the way it looks. That's what it's named. It's like my mother named me Doreen. For whatever reason, it's my name. She gave it to me. So this wave showed up like this. This wave showed up. They called this a P. This particular wave showed up. They called this particular one a Q. They call this the R. This is the S, and this is the T. And worldwide, it's just understood and accepted that way. Universal.
Got it.
Okay. All right. So again, if you see this P on the paper and it falls within the measurement of the EKG, right? Because right now we just talking about what it looks like. Make believe you don't know the numbers yet, but you got a piece of graph paper. So graph paper, graph paper has measurements. Okay, and so what we're going to be looking for is we're going to be looking for the same pattern measured out the same way on that EKG paper. Okay, so atriums contract. When this electrical SA node goes down here, go from SA node to the AV node. From the AV node, it goes down to the right and left bundle branches. And then they got these little fibers here at the end. Okay. Now, the other part to this is this. All right. When the heart contracts, you have these valves that's right here. Okay. So now if you take and feel slide down your thumb into your wrist and you can feel your pulse. And if you count it, right? If that number is anywhere between 60 and 100, you know that, okay, at least the SA node is working, because there's a rate of the heartbeats that you could feel in the SA node, and that's between 60 and 100.
Per what?
Per beat. So it's going to be fast or slow. Okay.
Wait a minute, I'm curious. You mean it's 60 to 100 beats per minute?
Correct.
Got it. Okay.
Correct.
So
okay. Yeah, that's what you meant by per what. Yeah.
Okay.
Yeah. So it could be fast, it could be slow, but yeah, it's per minute. Yeah. I'm sorry.
Okay. No, it's okay.
Yeah. So now, so having said that, I have to add something else. The unique feature about the heart is this: it has what is called automaticity. So it's automaticity. And I can put that in the chat, or you can put it in the chat. It's AUTO MACTICITY, automaticity. And what that means is that, okay, if the SA node is functioning, then the rate that I feel is going to be between 60 and 80. I'm sorry, 60 and 100. If for whatever reason it's not working, because of the heart's ability to regenerate or to generate and recognize that, SA node is not working, the AV node is going to try to compensate for what the SA node is not doing. But the AV node has a heart rate between 40 and 60.
Mm-hmm.
Okay, so SA node is between what? 60 and 100, right?
Mm-hmm.
And as long as everything is normal and you got a number in between there, you're good. But if you check your pulse and you see that it's 40, you already know that something is wrong with the SA node because of what? It's less than what?
It's less than 60.
It's less than 60.
Mm-hmm.
All right. And so if you get the number 40 or anything in between 40 and 60, you'll know that, okay, the AV node is working because the inherent rate for the AV node is between 40 and 60. If I could write that, I would write that. I would put 60 to 100 here. I would write here to the side. And then over here, I will put 40 to 60.
So a 60 to 100 for is normal for what?
SA node, let you know that the SA node of the heart, the sinoatrial node of the heart and the atrium is working. If you count that rate and it's between 60 and 100, all right. If you count that rate and it's between 40 and 60, it's like, oh man, the SA node ain't working, but and because of that, the AV node kicked in to take over for the fact that the SA node is not working. So that's where automaticity kicks in. So automatically, the AV node is going to try to take over to continue to make that heartbeat, right?
What's AV stand for again?
Atrial ventricular. So, and this is where all four of the, okay, so this is looking down here, the AV node would be right here because this is the connection point for 1, 2, 3, 4 for the two atriums and the two ventricles.
Mm-hmm.
So it's just it's the
So
location.
basically, if the sinoatrial starts to not function, the ventricles just automatically kick in for it, and they start working together to keep the heart pumping.
So you won't just say ventricles, you'll say the area of the atrioventricular node because it's more of a location.
So the atrial ventricular nodes are that is like that. It's that node right there in the center.
Yep.
Okay.
It's going to kick in. Mm-hmm.
Mm-hmm.
It's going to take over and it's going to try to compensate for the fact that the SA node is not working, but the range is only between 40 to 60. So it's going to try to make that heartbeat for at least 40 to 60. Now, is that, you think that's a good thing or a bad thing?
I don't think that's a good thing. I think if it's not normal, I think it's good that it's going to kick in to keep the keep the heart going. I think that's great. So it's definitely a great life-saving, secondary response to keep the heart going.
Mm-hmm. But it's not sustainable.
That's what I was going to say.
Right.
Yeah, right.
Yeah,
So
you're on the right track. That's exactly right. Okay, so now if you don't get between a 40 and between 40 and 60 on the heart rate, you come on down. You got the left and the right. These are bundle branch. Both of these are called bundle branch. Okay, and then it goes all the way out. And then these little things over here are called Purkinje fiber. So, but this area right here, the left and right bundle branch, all the way down to the Purkinje fibers, it has an inherent rate too. And that rate is between 20 and 40. So again, okay, you got 60 to 100, which is normal. And if something happens and it's not working, okay, AV node, the atrioventricular node is going to try to kick in between 40 and 60. All right. And so the person, you may look at that person, they might be sweating. They may have shortness of breath and they showing you, oh man, I ain't feeling good. All right. And then as it continues to go down to 20 or 40, they may pass out. Okay. But those rates are letting you know that the heart is trying to compensate. And unless something is done to correct it, the person is not going to have an easy time. Okay. So now.
So between 20 and 40, between 20 and 40 inherent rate is called what?
Those are Purkinje fibers. The Purkinje fiber, down
How
here.
do you spell it?
Purkingi. And the Purkinje fibers are responsible for that rate, I should say. And the Purkinje fibers are at the end of these are called the left and right bundle branches.
So it doesn't trigger an automatistic response.
Say it again.
It doesn't trigger an automatistic response. That's just for the
No.
actual.
All of these responses is part of the automaticity.
Got it. So the Purkinje response triggers at 20 to 4 beats per minute.
Yep.
Okay. And it keeps the heart going too.
Yes, but it's not a good thing. You know what I'm
Right.
saying? You in other words, you are recognizing the effects of what could be a dying heart if it's not corrected.
Right. If it's
But
not
as long as
assisted.
it's still going, you got something to work with. But yeah. So
Got it.
now go ahead. You gonna say something?
No. That's all I'm trying to figure out.
Mm-hmm.
Keep going.
So now, having said all of that, okay, when you look at what we saw before, when we said tachycardia and bradycardia.
Tachy meaning slow.
Tachy means fast.
So tachy means fast. Brady means slow.
Brady, Brady. Brady means slow.
Got it. Brady's slow.
Mm-hmm.
Tachy's fast.
Mm-hmm. Mm-hmm.
Got it. Mm-hmm.
So remember now, this is the sinoatrial node, right?
Mm-hmm.
So if you the EKG, let's look down here. Let's look. You see this where I am down here? It says normal.
Mm-hmm.
You gotta every time I hit it, it lights up. And you see the PQRST, you see that?
Mm-hmm.
So guess what that's called?
What's that?
Normal sinus rhythm.
Got it.
And guess why it's called normal sinus rhythm? Where does it originate?
I'm guessing the sinuses.
There you go. That's right. It takes on the name of where it originates. So for normal, when you have normal sinus rhythm, you know that you're going to see a PQRST, and you know that the rate, when you count up all of these EKG, the contractions, is going to be between a rate of what?
60 and 100.
There you go.
Ideally.
There you go. Now that's normal sinus rhythm. So now you see, and so now we're only seeing two right here, right? We only see two of the two contractions, but when you count it, it's going to be anywhere from 60 to 100, and it's normal because you see a P wave in front of every QRS, and it's followed by a T wave, and then the distance between those R to R's. The R waves on the top, the distance between all of those when you're looking at the EKG is going to be the same. So you only need to look at a 6-second strip to get an idea about what's going on. So that other thing we looked at when it talked about the seconds and had the millivolts, that was just giving you an idea about a 6-second strip, so to speak. Okay, so now.
So was it a 6-second strip diagnostic or a 6-second strip?
It's absolutely not diagnostic, but it just gives you a clue as to what's going on. You need to do a 12-lead EKG for it to be diagnostic, because now you're looking at different angles of the heart. That's what a 12 EKG does for you. This right here is just giving you a snippet.
So it's called a 6 EKG or a 12 EKG?
No, the 12-lead EKG has 12 leads, okay? The 6 seconds is just telling you how much of the strip you're looking at. So you could use a 6-second strip to look at a EKG, but this is not a 12 lead. You're only looking at one picture. This is only how can I say this? This is only one angle.
So what's the difference between a 6-second strip and a 12 lead EKG?
Okay, so the 12 lead EKG is going to give you, let me show you this one right here. Let me show you. And I'll explain it to you when I show it to you. Okay. Show me a 12 lead, because the I may have confused you, but the 6-second is it's just a time thing. It has nothing to do with the show me a 12. Wait, let me take this. 12 lead EKG. Okay. Let's look at, okay. This is better. All right, I'm gonna show you two things. Okay. All right. I gotta calm down. I get excited. Let me calm down.
I'm excited too. This is learning a lot. This is exciting to me. I love to learn.
Yeah, because you see all the you see all the math in
Yes,
here. Okay,
it's
and
beautiful.
okay. So let me just show you that what they're showing you. All of these different pictures that they're showing you, and so you could look at whatever that link is, but it's just showing you it's just showing you like this one right here. Okay, you see this one right here.
Mm-hmm.
All of those red dots, and you know how you get those things that you stick on the chest.
Mm-hmm.
This is putting a electrode on a particular spot on the body, so that when you look at the EKG, you end up getting a picture of the front and the back of the heart.
Mm.
And so when you position these leads this way, okay, because you see how it says, if I move the thing, oh wait, I can hit it. Oh yeah, if I click on it, it'll make it big. That's cool. Oh, I thought it would. Oh yeah. All right. So, okay. So this is left leg, right leg. Okay.
Mm-hmm.
Right arm. This is telling you where to put it. Left arm. You see that?
Mm-hmm.
All right. And then you see V1, V2, V3, V4, V5, V6. What happens? You put in V1 and V2, right? And so when you place that on the patient, you look at the collarbone, you go down, and you're going to put V1 there, V2 there, and then between the arm head, you put V5, and 3, 4 goes there, and then 6 at the end.
What does the V stand for?
So the V is for why am I blanking all of a sudden? The V is I want to say vestigial. I'm gonna tell you in a minute. Hold on. But it's written on the let me come back. It's written on each one of the cables that you're placing, each one of the leads that you put on the patient, you see the V1, V2, V3, V4, V5, V6.
Mm-hmm.
So the V, I want to say vestigial. That's the let me just come up here for a second. Oh, I'm supposed to know that. I'm supposed to know it off the top of my head. I just can't. But the point that I'm making is that those are all of the chest leads, but where is the but these placements, I will tell you, is the placement of them is standardized nationwide, worldwide. I'm gonna tell you what it means in a minute. But you see how this is right arm, left leg, and right leg.
Mm-hmm.
All right. So On a 3 lead, it's called 3, even though this is 4, on a 3 lead, that's when you see that PQRST,
Mhm,
the straight thing that we just talked about. A
mhm,
12 lead, however, is going to look, when you have all of these, or all of these, it's going to look like this.
mhm.
And you see the V1, V2, V3, V4, V5, V6. These are
Yeah,
these are the positions of those leads that we put on the patient. It's giving
got
you
it,
a different view of the heart.
got it.
Okay. And this is
Mhm,
lead 1, 2, and 3. Most of the time, what we look at is it's going to be lead 2 lead. It's 2 leads. Okay. But this is what this can give you a full diagnostic picture. Why? Because let me go back again. So having looked at this, I'm gonna come over here and I'm gonna go back to this other one. What that is doing is can you see that?
yeah, yes.
So this is showing you the different angles of the heart that you taking a picture of.
Mhm,
V1, V2, V3, V4, 5, 6. This is given all of that. Why is that important? That's important because let's go back to look at this picture. Okay. This is just showing you, okay, so those 6 leads is where you putting them,
mhm,
where you getting a picture of.
mhm.
And the importance of that is, okay, let me look at this one. Make this a bigger picture. Can I make this bigger? Picture image. What did I do? I'm trying to make it bigger. Can't. All right, so let me go back. Okay, so let's look at this. Let's look at this. Okay, you see where they have in these different points. This is something different, but okay. You saw that you had V1 here,
Mhm,
V2, 3, 4, and it went all the way around this way. So the aorta, pulmonic area, tricuspid area, and the mitral area. So the tricuspid area and the mitral area are those are valves of the heart.
mhm.
When you're looking at the 12 lead EKG,
Wait a minute. So I just want to make sure because I need to do a little more research. So
okay.
earlier when we were talking about the atrium and the ventricles, we were talking about chambers of the heart.
Okay, wait. I said aorta though. Aorta. I
That's
didn't
what I
say,
mean.
yeah.
Aorta, no. I'm sorry.
Yeah,
Aorta.
aorta is different than atrium.
Okay, I'm sorry. Aorta, no.
Yeah.
I'm sorry.
That's
Aorta.
fine. That's fine.
I was right with an A, but I just okay. So,
Right.
um, so I
I'm
need.
gonna I need to show you something. Haven't said that. I'm trying to find a better picture of the heart before we, because the letters are can be very confusing. So let me look at this. No, I don't want to do that one because it's talking about sounds. But I will tell you this. This is a good picture of an aorta right here.
Mhm.
All right, so that aorta goes all the way down and around. But the 12 lead lets you know that something's going on with that aorta. Hold on, I'm trying to get back to the.
So it's not the. So I misspoke when I said aorta. Even though the 12 lead will help you with the aorta.
You said atrium. Remember you said at first you also
Oh,
take.
okay.
Yeah, it was. I think there was something with atrium and aorta. It was the A.
Yeah, I'm getting the A's fit.
Yeah.
I'm getting atrium and automaticity and atrium.
Yeah, it's okay.
A,
I'm going kind of. I'm not trying to confuse you, but
no, it's there you go. So that's the aorta. So there's a difference between the aorta and the atrium.
yes.
Got it.
So that you got that. This right here is the aorta, and this is just showing you an aortic valve right here. That's this right here. While we having this discussion, this is the reason why I always go over the anatomy of the heart first.
Got it. I think that's a brilliant idea.
Yeah, I go over the anatomy of the heart first because the letters start getting confusing. But you say, oh, wait, oh no, that's right. That's the aorta, that's the organ. But when you go over the anatomy, I go over the anatomy of the heart. I draw a picture and I start out with the 4 chambers of the heart. And I talk about the direction of the flow of blood. So we talk about the flow, then we talk about the electricity. And how it connects from the heart to the lungs. I put the lungs on the side because it's connected.
Mm-hmm.
But we were talking about EKG, so that's why and when you asked about the 12 lead, I was showing you that it's just giving you a more of a thorough picture of the heart.
So how is the heart traced on the EKG if it's not with the 12 lead?
No, it is with a 12 lead.
So that's the only way the heart is traced on the EKG is with the 12 lead.
Yeah, it could be with the 12 lead or the 3 lead. It's just that the 12 lead give you a more in-depth picture of the front and the back.
Okay, great. So the pulsometer. Did I pronounce that right? Pulse oximeter.
Pulse oximeter.
So the pulse oximeter, it just traces the pulse and the level of oxygen in the blood, but it doesn't has the level. It does the pulse oximeter does not show up on the EKG.
It does not show up on the EKG. The pulse oximeter gives you a concentration. It gives you a number, only a number of how much oxygen is flowing in the blood.
Okay, cool. And that's a different
diagnostic tool
with a different interface that shows you the total, or that shows you the percentage.
How much oxygen is in it.
Yeah, exactly.
Mm-hmm.
Okay.
Are you in overload?
Well, no, because I'm really loving this. I might not.
Oh, okay.
You might not know, but I'm really loving this.
No, because I could go on and on and on, and but I'm just saying because you got to tell me when. But I'm just saying, I wanted to clear some stuff up with that right now because I still don't think you're 100% on the 12D EKG because I didn't see a good. This is talking about the valves. So I want to show I want to go back to no, this is just showing where to put them.
Got it. Placement.
Yeah, but the strategy. Okay, so let me say this: the strategies of these placements is that it's taking a look of the anatomy of the heart, and based on what that 12 lead. Remember, we just looked at the one EKG of the PQRST. We just looked at a contraction. But based on the 12 lead, you put all those things together and it'll tell you what part of the heart is being affected based on the wave, how the wave looks. So, what is this right here? Okay. This is kind of quirky, but
I actually like that. I think that's what more.
Yes, exactly. I'm just, when I say kind of quirky, I meant it. I don't like that it's dull, but this is like a good game thing.
Yep.
Because okay. So let me tell you what this is doing right here. If we look down here, right? Remember we saw on that 12 lead, we saw lead 1, lead 2, and lead 3. Now it's blurred out, but do you see what says 1, 2, and 3? So on that other EKG paper, it had the Roman numeral 1, 2, and 3, and it had the blocks and stuff, right? Then remember we saw V1, V2, V3, V4, 5, and V6. Okay, so now when you look at that, this is how they got it color coded. Okay, AVR, AVS and AVL. So these two blue parts right here, 1, 2, and 3, and 4, is telling you that this is the part of the heart that this is looking at.
Got
Okay.
it.
When you look at that's the way it usually is. So where's the green? So with, let me see here. Okay, left atrium. The color code, I don't see purple. Okay, here's purple. Here, yeah, so AVR. So it says right here, so which artery is likely the culprit? So let me say this. Let me say this. Okay, let me just go back a second. Because I have to go back.
So there's chambers, valves, and now they're saying arteries.
I'm getting ready to explain that. That's what I'm getting ready to explain to you. That's
Okay.
the culprit that I'm getting ready to explain to you. Okay.
Mhm.
You have the coronary arteries, right?
Mhm.
Which is the outside, because everything we talked about is we were specifically talking about the electrical conduction of the heart, and how we need to identify normal sinus rhythm, right?
Mhm.
And identify what is normal before we know that, oh, this is different.
Mhm.
What we need to do is now we look at the whole heart as a whole.
Mhm.
You have the coronary arteries, which are on the outside of the heart.
Mhm.
Okay. You have the coronary artery, which it feeds over here. And then you have the right coronary artery, it's coming from the back this way. Okay, so you see how you got the wall right here, and this particular coronary artery is right on the wall of the heart, right?
Mhm.
So it feeds into the lateral wall of the heart, and it's telling you that.
Mhm.
Okay, the left circumflex lateral wall artery, left atrium, SA node, posterior left ventricle, posterior septum. All of that is what is this affects right here.
Mhm.
Okay.
Mhm.
And so the coronary arteries, when it says what supplies what, okay,
Mhm.
the left is supplying the left atrium over here. The right coronary artery is supplying the inferior wall.
So the artery is the attachment. The artery is a major, I don't know what to call it. It's
Yeah,
not a valve.
it feeds off of the aorta. So this is the aorta,
Got
but
it.
the coronary arteries is a branch off of that. But one part supplies the inferior wall,
Mhm.
okay, the lateral wall, and the anterior wall of the heart.
Okay, so could you repeat the walls, please?
Yeah, you got
So
the inferior wall,
mhm. The anterior wall, the
and the
lateral.
posterior wall, which is in the back. Anterior is in the front, posterior is in the back.
Got it.
And
Okay.
so
So the wall is the exterior of the heart. It's the exterior of the ventricle and the atrial. Is it atrium?
yes, but it's more ventricle. It's more feeding to the vent, but yes, it's
Okay.
the wall of that. Yes,
So
it's so
it's basically exterior surface around those parts of the heart.
feeding into the heart. So it's like,
Feeding it.
you
Okay.
got a spider web on top of something. So
Mhm.
it's like those vessels are on top of the heart, feeding particular parts of the heart. And if
Mhm.
it's not functioning, it's going to show up on the 12 lead EKG. That's why the 12 lead EKG lets you know what part of the heart is being affected. Is it the septum? Is it the lateral wall, inferior wall, posterior wall, anterior wall? The 12 lead can do that because
Mhm.
it's gonna have a different look. That's a different thing when you learn how to read a 12 lead. You read them in groups.
Got it. What other groups?
So you got, here they go right here. So AVR, AVL, AVS. So you see how these colors is one AVL, V3, and V6. These four are read together. All right. You see what I'm saying? These two are read together, and these two are read together, and then these three.
Okay.
And by
So the
definition,
purple one is by itself.
the purple one is by itself. They call it augmented. It's just like a placeholder, but it has to be there.
Okay.
It's like a grounding.
Mm-hmm.
So yeah, so when you're looking at it, when you're looking at the EKG, you see that one group is the one AVL, so that's on this thing it's the blue, and the V3 and the V6.
Mm-hmm.
Okay, so if we look at, let's go back and see this is a fun one right here. So they kind of did it here again too, but they just did it without the heart. They just got the groupings of the colors. 1, 3 AVF, 1, 2, and lateral. So let me go back. It keeps going. Oh, it's just going back to, okay, I gotta do this. From here. These are sounds. I don't want that. Same thing, right?
Mm-hmm. So each one of these leads represents a location on the heart.
Collectively, when you group it like this, because remember you remember how it's placed, where you got V1, 2, 3, 4, 5, and 6.
Mm-hmm.
It's surrounding the front of the chest. Remember that?
Mm-hmm.
And then you got the right and the left arms and the left legs. Okay, so that's just the surface. But around the heart, this is telling you inferior leads, okay, are the 2, 3, and AVF. These three right here.
Mm-hmm.
And the lateral leads, remember we just talked about down here with this picture, we show where the lateral part was and the posterior, inferior. So it's specifically letting you know that these colors of where these grouped leads are is telling you what part of the heart is being affected. And the cardiologist would be the one that would say what specific disease this person may have or suffering from, or what, or a coronary artery disease.
Mm-hmm.
Okay, one of those coronary arteries have been, they're either closed or they may have burst. Okay, and again, so on the 12 lead without let me go back. So this grouping right here is a standard grouping. You know what I'm saying? You would always look at, so you would have this as your guide, right? And so when you're looking at the group, you want to see what's happening with V3 and V4. V5, V6, V1, V2. You'll know that this right here is septal, this right here is anterior. Okay, this is inferior part, and these lead 1, 4, and 5 are lateral. This is like a standard, so they put them in the color so that you could kind of see it.
So is this a standard chart?
This is a standard chart.
Got it.
Yeah, so meaning that 1 and AVL is always read together. The green and V5 and V6. You're always going to look at those and see, and it should look like this. They want it to look like this. This is just showing you with that particular. So let me go back. So I hope I can get back to this, but keeping that in mind. Okay, so now you see how you got V1, 2, 3, 4, 5, and 6. All right, so this is how it's placed on the heart. But now your standard 12-lead EKG is going to come. It's going to look like this. All right, and so it's going to in terms of identifying what part of the heart is being affected, you got to remember that 1 and AVL and V5 and V6, they color coded so that if you're looking at something's going on with the lateral part of the heart, 1, 2, these are the 4 that you're looking at. And that's something that's learned. You know what I'm saying? That's something that's learned. So this is just a whole straightforward, put the EKG on, and then now that's why this is more of a diagnostic tool, because you're comparing what's happening at the different locations of the heart. You're looking at that.
But you can look at this and you know
I can look
exactly.
at this and I will say that, okay, so I'm looking at, I'm always looking for, is there any elevation in the ST segment? And remember, the ST segment is, remember when we got the QRS, you got the PQRS, and then you have the T, right? So this line right here, let me just show you an example. This line right here is called your isometric line, right? So what I will be looking for is this ST segment. Does it go up here like that? Does it go up here like that? Because if you have, the biggest thing that you can see is if this line goes all the way up, that person is having a heart attack. You can tell.
And that's the T.
It's the ST. It's called ST segment elevation.
Got it.
Where the ST segment is elevated.
Got it. So we don't want the ST up there with the R.
No, the ST won't be up there with the R, but okay, so that elevate, okay, no, we don't. But the main thing we look at is that you see how the T should not be more than 2 of these blocks going up, remember? Because remember,
Got it.
all right, but if we see it going up here and it sees this one is coming off of the isoelectric line, yeah, it's a little bit okay. But is it happening in more than one thing? And so yeah, the person could be having a heart attack if you see this thing going up. So what'll happen is this whole line is going up and it's like, oh wow, it's not flowing the way that it should. Okay. And then you see something, let me see if I can see what it show me. I'm gonna ask it to show me a heart attack EKG. Let me see if we can do that. I bet you if I ask Chat GPT, I probably could. It's giving me explanation. I want to see EKG.
Well, here's what I'm going to do. I just need to know. It seems like the airway is going to be the focus for September. Is that correct? Or is it going to be the heart? It's going to be airway, correct?
It's going to be a combination because the two work hand in hand, but we're going to break it up in chunks.
Okay. So the reason I'm asking is because I'm trying to figure out what daily practice the learners can receive in the month of September. And what I typically like to do with math practice is have it start off extremely easy,
Mm-hmm.
like color activities and just
Mm-hmm.
basic numeracy, just to introduce it in ways that aren't intimidating, and then gradually increase it in complexity as they progress. So what I'm trying to do is align the math practice to the targeted outcome of the EMS curriculum.
Mm-hmm.
So the thing is to know what the desired outcome is by the end of a certain time period, like what the learning objectives and goals are.
So I would say the concentrations of oxygen with the various types of airway adjuncts and um uh the oxygenation tank, because remember it's PSIs and you got to know how many liters, you know what I'm saying, dealing with either one of the masks. Let me I don't know if you kind of picked that up on the little snippet thing, but if I'm hearing you correctly, that's the way I'm thinking.
Hmm.
Um, the airway management component.
Hmm.
Um, um, with the nasal cannula and how much oxygen is needed for that, and actually what it's called, the percent oxygen.
Could
Um,
you put all of that in the chat?
I thought, let me see. Go here. Okay, so see. For airway management, the important um
And the units are read in PSI, which is, what is that?
it's per square inch. Oh no, pressure per square inch.
So that's the pressure per square inch, which
PSI, yeah,
means,
the measurement of
so it's probably, so here's my question. Even though it's pressure per square inch, it's still using the metric measurement, I imagine. So hold on.
yeah.
Okay.
Mm-hmm. And that's in relation to what's written on. So I don't know, when I showed the little video, the bottle has a gauge on it where it has the PSI,
Hmm.
because those bottles are pressurized.
Got it.
And so that number is coming from for lack of a better word, the pressurization of the bottle
Hmm.
in PSIs. And so when an EMT goes on shift, you got a green area and a red area. You always want to make sure it's in the green area, which is going to be at least 1,000 PSI,
Which means the tank is full.
which means the tank is full.
Got it. And so where does the tank get loaded?
You said when?
Where? Yes.
So there's companies that do that and they buy the bottles. Most, like DC Fire, they have a filling station where you go and you fill it up. But there's also oxygen companies where when your bottle is empty, you go to your station and you got a rack where there's full bottles and you got a rack with empty bottles. So
Hmm.
you replace.
Got it. So you just basically, and then they fill it up and put them back on the shelf.
Yeah. You
Got
just
it.
replace what you have. You got, yeah, it's like, yeah. You go in, turn in your old one, and pick up a new one. You don't wait and get it filled. Now with DC Fire EMS, they do fill bottles, but that's because they have a whole apparatus. But most private places and stuff like that, they just, and it's delivered. It's delivered to the firehouses too as well.
Now, is it? Well, that's another sidebar.
What's
So
that?
go ahead. No, I'll ask that at another time. I just wanted because there's this huge trend to oxygenate the blood by taking in large portions of oxygen because it's said that it has healing
Yes, it
effects.
does. No, that's very much related. So let me, yeah. So here's what okay. So let me calm down.
I'm excited too. Don't feel
Um,
alone. Don't feel alone.
so the cell itself, right?
Mhm.
The disease process starts when the cell cannot be properly oxygenated or get glucose. Those are the two main things. And it's powered by the mitochondria. You familiar with the mitochondria, right?
I know we get it from our mother.
The mitochondria.
From what I understand, it's passed down through your mother. But that
The mitochondria.
maybe I'm thinking about
Yeah,
something
you
else.
think about something else, but
Okay.
because every cell, um, it's it's life. I mean, okay. Let me put it to you this way. You know how they say, where these kids get all these energy? They running all over the place, right?
Mm-hmm.
And then when we get older and we slowing down.
Mm-hmm.
So the mitochondria is found in every cell.
Mm-hmm.
As we are born, we have a whole bunch of them.
Mm-hmm.
And that's the powerhouse of the cell.
Mm-hmm.
But in order for that cell to function, you have to have the right amount of exchange of oxygen and glucose, which is sugar.
Mm-hmm.
All right. And so, based on the mitochondria, that's what gives us the energy to do what we do. And it generates two major things that are that helps to fight against free radicals.
Mm-hmm.
And the free radicals are the things that you could you can combine that to like rust. Things rusting away, the stuff starting to break down. Our
Mm-hmm.
bodies break down when the free radicals are not taken care of, which is normally taken care of by the mitochondria doing what it does to create what's called, there's two major antioxidants. There's a whole bunch more, but two of the major ones is superoxide dismutase, and then there's another one, glue, it starts with a G, I forgot. But anyway, so when the mitochondria can't make antioxidants to fight off these free radicals, that's when we start to feel pain and get sick and all this kind of stuff. So what happens is that as we get older, our body loses its ability to make mitochondria. And that's why we can't, when we get these little kids that's running all over the place, they get on our nerves because we don't have the energy to deal with them.
Mm-hmm.
So they have a whole bunch of mitochondria because they got that energy, which as you get older, you lose it. But now, if you can oxygenate the body,
Mm-hmm.
okay, and so it's oxygenation will provide those mitochondria to stay prevalent where they need to be.
Mm-hmm.
There's certain foods and certain things that will help the mitochondria do what it's supposed to do, but oxygen is one of the key factors.
Mm-hmm.
And so if you could keep the oxygenation going, the idea is that it keeps the mitochondria going, which keeps us the energy going so that we could create these these antioxidants to fight off these free radicals that allows the disease process to happen anywhere in our body where there's a lack thereof. If that makes sense.
It makes a lot of sense.
So this oxygen, and that's why Michael Jackson had that hyperbaric chamber.
Oh, I didn't know that.
Yeah, he had a hyperbaric changer, and what that does is that forces oxygen into your system. Like people that got bad, in some hospitals, like GW, I think they have 2 hyperbaric chambers, and when persons who suffer bad burns, of course, they put them in these hyperbaric chambers, and it forces oxygen into their system at a controlled kind of rate.
So would it be wise for me to breathe some oxygen from an oxygen tank occasionally?
It would, but you also got to make sure that every, what I'm saying, it doesn't hurt.
Mhm.
It doesn't hurt. But what happens is that we get so bombarded by everything else that anything we do is going to help. So even like right now, we, us using the computers and the 5G, what happens is that these electromagnetic forces, they affect our body over time. It's already been proven. The science is out. We can do things to help our body to because we're not going to stop using the phones. We're not going to stop using them. So we could do things to protect our body, put barriers down to protect us, or things to help replenish our body's ability to fight off, what this electromagnetic frequency is doing to us. So it's, I know you said it's a whole nother story, but it really is all related because it's the holistic approach. I mean, it's you can send me into whole new thing with that, but but it's all relative, because if we could keep, so let me go back to another thing. Balance, homeostasis, balance. If we could keep a balance, our body really is supposed to be able to fight off any and everything. But because of what we've been exposed to, is an imbalance of what we've been bombarded with the capability of our bodies to fight it off based on the way we eat, the way the environment is, the whole 9 yards. And it's mainly our environment, because this electronic stuff is really what's kind of like killing us slowly. But we're not going to stop using it. But we need to be educated on how we can make a balance or use it safely. And I don't know why they don't post it out. Like our phones, there's a thing on there that tells you, that it can cause cancer. They have a filter on there that you can turn it on your phone to kind of slow down the emissions on there. Then there's other healing things where you could either put on or wear to help to fight against the fact that when we get, the other part is that when we get hit with these frequencies a long time, our bodies loses minerals. And we have essential minerals that we need to keep functioning, when the bones start aching, this, that, and the other. And it can only be replenished if you are getting it from the outside. And the foods that we eat, the minerals and the soil ain't the same. We got a lot of pollutants and contaminants and stuff. So we just not getting what we're supposed to get. So to answer your question, yeah, it's however you can get the oxygen is good, but it's still a balancing act to make sure that, and if we don't get enough sleep, that's another thing, because our body, we supposed to rest. I am notorious for that, and I'm getting better. When we sleep is when things, your body's at rest and not fighting to keep doing what it's supposed to do. It's supposed to be rest so that it can, okay, now I'm going to replenish. And if you don't get enough sleep, it ain't gonna happen.
So I've been planning to start riding my bike. Riding my bike every day to get some exercise in. Will that, just breathing heavy, help to increase my oxygen intake?
Yeah, it does. It does.
But it's not the same as if I were to also have the assistance of a tank.
See, so if our body was functioning optimally, you won't necessarily need that. But it doesn't hurt, if that makes sense. Because you got to consider other things. You got to consider, the eating right, getting the right nutrients, Moving is always 100%, because as we get older and don't move enough, that's a problem. That's a major problem.
Mm-hmm.
Because as you move, your body's going to generate what it's supposed to be generating. But the question is to make sure that everything is functioning the way it's supposed to be functioning.
Mm-hmm.
And you know, the essential stuff we should be getting, like, you know, the essential minerals and stuff like that, we should, you know, be getting that, and make sure we getting the right ones that's not full of junk, you know, and that our body's really absorbing and making a difference.
Got it.
So it's, I mean, this stuff is phenomenal. It's so many classes I want to take, it's just unreal.
It's a lot of classes you can teach too.
Well, you know, I get excited about teaching EKG. Why? Because that was one of the most difficult subjects when I was coming through paramedic school, and now I can do it with my eyes closed almost. In the sense of just trying to, you know, not to make people, just to let them understand that, you know what, this stuff makes sense.
Mm-hmm.
If you know that I mean, it makes sense, and it's something that you can understand. It looks all complicated, but it's like, wait a minute, we could break this down so that you can understand why it is. Because now every time when you take a pulse, you know that, okay, if as long as that rate is between 60 and 100, okay, SA node is working. Anything less than 60, that person, unless they're an athlete, okay, if you get something like a 40, you already, that's a person that's probably unconscious, unresponsive, and you trying to see, do they have a pulse? And if you
So athletes have slower hearts?
they do, because they it's not abnormal for them to have a normal rate of 60. If they're athletic, don't be alarmed, because their body has adapted to that type of circulation. So that's one thing, is that it's not unusual for them to have a heart rate of 60.
Got it. Okay. So here's how I think we should spend the last 15 minutes. So we need to get ready for the next session, which I would love to be sometime next week. Um, let's create some action items, or I can also email you some. What I definitely will need from you is, number one, I'm going to send you a form to fill out. Um, it's a PD form, just saying that you've completed some professional development to prove it, and then we can send it to Crystal, and just write what your experience was, what was discussed. So the PD form,
It's as far as you and I.
yes.
Okay.
Uh-huh. Um, um, I'm putting it into the chat, like what your experience, um, what we discussed.
When you say my experience, you mean what experience I have, or my experience that I possess? Or when you say
Oh, what was your experience with the professional development session?
that
Because
we had.
that we're having, because right now we're in what's called the discovery stage. So in the discovery,
Okay, I'm glad you told
yeah.
me.
So in the
Okay.
discovery stage is I need to discover where you can
Okay.
get enhanced support. So that's why I've been listening, and I've learned a lot.
Oh,
So I had to learn where math is pragmatically and commonly used, and it's used in a lot of different areas.
yeah.
Um, so it's used from everywhere from liquid volume to air volume to um, charts and grids. There's there's a lot of math used on a day-to-day basis. So now we have to continue to build on that and then start to single out where there's going to be a concentration. So it seems like there's going to be a concentration on airway management. And since there's a concentration on airway management, then there's an opportunity to study the oxygen tank, but there's also an opportunity to study the um, pulse oximeter, oximeter,
Pulse ox, yeah,
the
You can
pulse
say
ox.
pulse ox for short. You could just say pulse ox for short if you want to.
I want to get it though. I challenge myself, so I'll say pulse oximeter. Is
Yep,
that
there you
correct?
go. Yep, yep.
So we need to study oxygen. We need to study the pulse oximeter. Then there's different types of airway management tools where there's pumps, and then um, there's resting times. There's we're not yeah. There's the suction that's more to do with duration time. Versus 10 seconds for a trauma patient and 15 seconds for a
Med.
medicine, a medical. So
Mhm.
so yeah, it's like so this stuff has to be taken and made into a way
Gotcha.
where
Conceptually.
say again.
So it's a concept. It's made conceptually.
Yeah, and here's the other thing that I've learned too is that like I've even learned it in this session when there's someone like you who has a lot of experience that experience came over time.
Yeah,
And
yeah,
for someone who is building experience, they just need to spend more time,
yep,
on a
yep.
continuous basis. So
Mhm.
um, I think that we have to figure out a way to say, okay, let's get you this practice so that when you get into the field, you're familiar with what's going on and it's not foreign to you.
Mm-hmm.
So the
Mm-hmm.
way that I think that we give them the practice is give them activities that embed scenarios that they do daily, just like if they were a paramedic.
Right.
So I think our curriculum should literally be structured that way, where it's aligned to what they're going to encounter in the workforce.
Mm-hmm. Which would be which would be so there are some materials out there that have different scenarios that are based categorically, like a scenario where um the main outcome you want from that scenario is that EMT knows how to manage the airway,
Hmm.
or that EMT knows how to control blood, or
Hmm.
that EMT knows how to make a decision as to when it's time to load and go or stay in play. Meaning
What does
rapid,
that mean? Yeah.
meaning rapid. Okay, this patient may be going down the hill. I need to recognize that based on what I see. I can't stay here and take all these vitals. I need to make a decision for it to be a rapid transport.
So here's what I've taken from where how we can kind of tie math in,
Mm-hmm.
because I'm learning that there are very, very important critical decision skills that must be made that do not necessitate math when it comes to a patient assessment. And then there are skills that definitely necessitate math.
But
So
time management fits into all of it, though.
I agree with you wholeheartedly,
Yeah,
especially when it comes to duration. No, I'm agreeing with you. Like,
yeah,
them evaluating the patient and knowing whether or not I should try to apply some type of medical intervention here, or whether I should just try my best to get this person to a hospital because it's that dire. That's very important. And I'm sorry if I sounded all
Well, no,
dismissive.
no. Look, well, let me say it like this, because I can say what you're saying and just make it sound a little bit better.
Mhm.
You make the decision to not treat them on the scene, but you get them inside of the unit and then treat them in the unit,
So what's the unit?
the ambulance, in the
Got
ambulance,
it.
in the
Okay.
ambulance.
Okay, cool.
And
So
so it won't seem like you just try. Let me help you just get them out of here, and I ain't doing nothing. Let's just get there fast.
no,
So, but
no,
no,
got it.
no. But I was just trying to say it in such a way. No, I'm not saying
No,
you said that. I'm
no,
not
no, no,
saying.
no, no. I get it. What I'm saying is that you have no idea how much I appreciate what you're teaching me, because you you understand and you speak your industry's language, and I'm trying to pick it up. So one thing that you said was, um, you mentioned the approach to whether or not you should apply medical attention on the spot, or whether you should, what did you term you
Treat
use?
them
Like,
in treat them in the unit.
right, treat 'em, but you use a different term, like pack them up and go.
Oh, stay and play or load and go.
Yeah, that's it. Stay and play or load and go. So so that terminology, and it's like, well, what does stay and play or load and go mean? It's like,
Right,
okay,
right, right.
stay and play means that, like if they got stung by a bee, and
Yeah, you got a little time,
yeah, and you're not allergic, or if they are, you have the anti venom, whatever.
epinephrine pen. Uh-huh.
Right. See, you know
Yeah.
exactly what you need to do. So it's like, that's not a load and go. But if someone has, God forbid, some type of traumatic event that causes them to need that type of care, then by the assessment. Um, so that critical skills thinking and discernment is very important. But
But
once you
I just wanted to add one thing, which you're right what you said, but let me just say, and I'm just saying this just so that you know, not
Okay.
because I understand, I know that you already know this, but
Hmm.
that patient that gets stung by a bee, you got the epinephrine pen, that's a load and go. And I'm gonna tell you why.
That's deep.
Yeah, I'm gonna tell you why, because if you have to use the epinephrine pen, the thing that you have to worry about is that, okay, so the person may have some swelling. The
Hmm.
thing that you worry about is there any swelling in the face, around the mouth, or the chest?
Hmm.
Because just like your skin could swell up, guess what? Your trachea could swell up and the airway will
Mm.
close. So
Mm.
that's why you don't play with a person who has a anaphylactic reaction. It's called anaphylactic, and it's a
And
reaction.
I minimalized it, and I would have failed the test.
I,
I'm
and
like,
that's what
yeah,
I
just
said.
give him
I said
epinephrine.
I can't let him. Actually, I can't let him go by. I
No,
knew
I'm
what you
so
were
glad
trying
you
to
did.
say.
That's
I knew what you were
exactly.
trying to say, but I said, no, I gotta let him know that. Wait, it sounds like it's something, but it's. Let me just tell you the
It sounds
implication.
like it's exactly. It's like it's like, yeah, these things are much major. So that's exactly why we need this professional development. That's why I need it, and that's why I need it. I- I'm
I
learning.
said, wait, I said, I can't let him. I said, I knew what you meant. I knew where you was going, but I said, wait, I have to interject.
That's awesome. That's the whole purpose of this. This is beautiful. I love it. So again, it's like, so that's a load and go. That's not a stay and play. So
Correct.
so then we have to get them into the unit, which is another form of language where the unit is an ambulance. So
Mhm.
so the thing that I'm envisioning is those type of exact scenarios where we're incorporating the math. Like, I think the curriculum that should literally be American Mathematical Day in the Life. So
Okay.
the curriculum is going to be a day in the life of uh, an EMS.
Yeah, I was gonna say EMS. That's perfect. Yeah,
Yeah.
that sounds perfect.
So the day in the life of EMS professional will require them to know some basic arithmetic and numeracy, and we're going to get
Hmm.
that daily practice
Hmm.
that will guide them gradually into how to read an oxygen tank, or an pulse oximeter, or how to read an EKG. But it has to be gradual, and we need to also make sure that they have the foundational basic skills of addition, subtraction, multiplication, and division, but that are based on current standard alignment with conceptual understanding. And then they also need to seem like they need to learn things like just terms like beats per minute, and Um, um, is it pound PSI again means pounds?
Per
No,
square
not
inch.
per square inch or yeah, something per square. So yeah, per square inch. So PSI means
Yeah, pressure per square inch, PSI. Yeah,
you're right,
it's written on the thing. It's yeah.
right. So they have to learn beats per minute, pressures per square inch, cc's, milliliters. They need to understand that when it comes to an IV bag, that they're coming in different sizes from what is it, 50 cc,
250, yeah, you could be it could be yeah, and it could be, it could be
50
20,
cc,
50, 100, 250, 1,000. Yeah.
right? So, and then they need to understand the difference between the substance and the solution or the solvent. So, how much how much of a concentrate is going into a solvent and how to administer. So it's all this different math that goes in the day of the life, but I think we have to kind of like categorize it in the
Mm-hmm.
two major categories that I see that are the most predominant from this conversation
Mm-hmm.
is is there's liquid volume and then there is air volume. So
Okay.
there's
Okay.
liquid volume and there's air volume. So the air volume is airway management. The liquid volume is, um, of course, the management of the heart and the circulatory system, but also making sure to clear the trachea from any type of obstruction or to clear the airways. So that again is airway management, and you don't want the liquid volume to drown the person and by
Mm-hmm.
interfering with the air volume. But it seems like the two types of management is that there's liquid outside of the person's body and there's liquid inside of the person's body that
Mm-hmm.
has to be managed. So that's
Mm-hmm.
liquid volume. There's air outside of the person's body and there's air inside of the person's body. So
I
they
like
have,
that. That's a new concept that
right,
makes all the sense in the world.
right. So it simplifies it and then we can categorize it. And by simplifying and categorizing it, we can see where we want to prevent overlaps. So when we look at the heart, for instance, and you're reading the EKG, there's definitely a relationship between the heart and the airways, but the heart is really a part of the circulatory system and it's a pump that's pumping this liquid volume. So we can conceptually understand that, oh, there's a pump inside of this person's chest that's pumping liquid throughout the body. So now we can conceptually understand the circulatory system. And they said, but there's this other organ called the lungs, and that lungs, it's taking in air volume, and it's taking that air volume and it's putting it into the blood so that can be pumped. So these are two different systems that work intimately with one another to produce life. So
And
we
you know
have
what they're called?
talk to
One
me.
is called the systemic system, and the other one is the pulmonary system.
Very
And they
nice.
have to work together. So the way you just said it is the way it really is.
So let's just make that
Mm-hmm.
exact same pragmatic actual existence, let's reflect it in the way we give the math instruction. So
Mm-hmm.
we'll concentrate on air and liquid volume, and then we'll teach the math around. Now, when it comes to the EKG, which is an awesome tool, it's a
Yeah,
tool.
we can wait.
Well, no. I'm not suggesting that we wait. What I'm suggesting is that we just understand that this is a way of telling the learner for if we're measuring the the pump of the heart,
Yes.
we're still in the circulatory system. But if we're looking at that pulse oximeter, then we're measuring the percentage of oxygen in the blood. So that's telling me how much oxygen is in the liquid. So it's showing you that marriage between airway and circulatory system.
Correct. And see, it's for that reason that the two we didn't the one part we didn't talk about is we didn't talk about how the blood flows from the heart to the lungs. That right there, Once you, that right there is the starting point of everything else, for real, for real.
Really?
And yeah, it really is.
You know, I'm gonna have to resist the temptation to have you go into it. I
I
want us
know.
to talk about it next session.
Yeah, we will.
What's the type? What's the name of that transition from the blood from the heart to
It's
the?
just it's okay. It's just the circulatory system. It's
Got it.
the pulmonic system and the systemic system. The two work together.
Got it.
You can't have one without the other. So the way you explained it, and so for me, conceptually, is what I want the kids to understand is that it's not a separate thing.
No,
And so,
that they're definitely not separate. But what we have to explain to them is that they're separate outside of the body. What do I mean by that? Okay, even though you can take in both air, liquid, and solid in your mouth, we want to make sure that they channel to their appropriate places. We do not want the only thing we want going into the trachea is air. So we're going to study airway management. The only thing we want going into the trachea and the lungs is air. There is an esophagus where we can take in both solid food, which we chew to convert it into a liquid, and then there's also water or other liquids that we can take in through the esophagus. You can take in some air going down the esophagus, but you want to minimize the amount level of air. If you take in too much air, that's where you have indigestion, you have burping, because you're not supposed to take air to your esophagus. You definitely don't want to take anything liquid into your trachea or your lungs. Okay, so
right,
there is a way that the body combines both air and liquids, but the body likes to take in air and liquids. So what we're going to study is we're going to study air volume and we're going to study liquid volume. Then we're going to study how the body takes both of these substances to give us life. You know, if there's anything else that goes into the body that's not air or liquid, I'd like to know what it is so we can categorize it appropriately.
well,
But right,
one thing I want to add on that list is that because when we use the bag valve mask, you know, giving them the ventilations with the airway adjunct,
mm-hmm,
if we give too much force, because
mm-hmm,
this came to mind when you were just saying what you were saying, if it's too much force, oxygen into the esophagus will cause gastric distension.
mm-hmm,
And that's the term for causing them to vomit. And we didn't really like say that,
mm-hmm.
but the force of the amount of the volume of air that you put in, if that volume and the force is too much.
So what happens if you have a container and then you take something like, so let's say you have a cup of water and um you put a hose that pumps air into that cup of water.
It's gonna spread out.
That's what the vomiting is.
That's right.
So now we can simplify it to
Mhm.
learners understanding that these tools manage liquid and air volumes,
Mm-hmm.
and
Mm-hmm.
everything can be traced back to liquid or air.
Mm-hmm.
So when I'm looking at a pulse oximeter, I know that that's telling me the percentage of air that's in the liquid or
That's
called the
right.
blood.
Hold on 1 second. Hold on 1 second. Okay.
So I've learned a lot today. So what I try to do, because I was the type of learner where I, when I was coming up, and I'm still the type of person today, I really like to simplify things and
Right.
make them super easy so I can kind of
Yep.
like, so for me, I was just trying to really figure out what type of math is being used on a regular basis. Now, the other thing that there's in addition to with that EKG is that's actually a measurement of electricity.
Yeah,
So that's
yeah.
something totally different. But
Mm.
I didn't even think with that we're measuring it relates to we're measuring the pump that's in the body pumping the circulatory system.
Well, it
And
is. It's more like you said, the measurement of electricity, because that's where the millivvolts came in. You saw that diagram we saw.
mhm.
Because it's really the way that it. I kind of went all over the place, but I don't teach it that way. I was showing you the relativeness of the rates and the automaticity of the heart,
Well,
and how when you take a pulse.
well,
But
can I compliment you and say that you gave one of the most incredible overviews. I'm serious. Like I'm telling you, I came into this conversation with zero understanding. Okay. A- And you gave me a lot. Like you literally gave me enough where I would have to like literally go back and study what I've learned today
right,
for maybe
right,
2 to 3 months.
like you taking a class or something, right?
Yeah, it's like I took an intensive. It's like this is your intensive just so you get a general overview. And this is the introduction to your intensive. It's not the complete intensive. You
Right.
know. So I've learned a lot, and I think this is awesome. This is awesome. I just pray that you know Crystal and Ossie continues to support it because by us working together collaboratively, we can preserve,
Yep.
your lifetime of experience and prepare it for curriculum for future generations.
Mm-hmm.
And then we can also adopt best practices and
Mm-hmm.
we can test out materials and it's just a lot of good stuff that could come out of it. So no, you gave a beautiful overview and I've learned a lot. I'm eager to learn. I'm eager to learn much more. But I really would like to give you the support that you need for this upcoming school year by providing practice materials for the
Mm-hmm.
learners.
Mm-hmm.
I
Mm-hmm.
can actually have some activities in there. How many learners are,
It's 18. So far, I know we got 18.
okay, cool. So I can actually have activities for them to practice with starting. I'll send you for the month of September, we'll just have printouts,
Okay.
but it would be great if we can have some stuff in October ready, like actual handheld booklets of practice material. Um, and the learners are probably going to think our stuff looks like kindergartners could do it.
No, because they take well to so I have a lot of diagrams of different body parts, stuff like that, that's coloring and using
Yeah,
crayons and stuff like that. So they do.
that's okay, perfect. So that's exactly what we need to build together. So the thing is, when can you meet next week? Because next week is school starts on the
Yeah,
28th.
Wednesday, Thursday, and Friday is bad for me, so it's got to be like Monday or Tuesday, and I gotta figure that out. Gotta figure that out.
Okay.
Um,
I just need you to email me the time, or I'll send you over an email with our calendar,
okay,
and then you can just fill out what's a good time, and then we'll schedule for that time. And then I'll try to have something for you as far I'm trying to think what
I gotta get ready to go. I gotta go pick up. I gotta go to the metro get my husband.
no, that's good. I'm glad that you, I mean I wouldn't- it's not good. What I'm trying to say is I just need to make sure I have your materials for the learners for the first month. And I'm trying to think, but we'll discuss that next meeting. So go
Okay,
pick up who you have to go pick up. That's
okay.
perfect. I really enjoy everything.
I enjoyed it too. As you,
I really
I'm passionate about this stuff. I really like it. So I mean,
yeah,
I
me
kind of
too. Me
I
too.
get a little bit.
Yeah, if you can give me definitely a good time for Monday as well as a an overview of the lesson plan for September, October, and November, then we can start aligning the academic materials.
Okay,
All right, I really appreciate you, sis.
you're welcome. No problem.
Okay, I'll talk to
Uh,
you on Monday. I look forward to that schedule.
Okay, all
All
right.
right, thanks a lot. Be safe.
Uh-huh.